the spirit of understanding, the spirit of wisdom, the spirit of this one, Lord, let this agenda
Amen. Next on our item, we have a recap of the one activity. So we are not going to do it as director led us when we were busy. When I bring up the topic, you tell us what was discussed yesterday. Something briefly, like how you got it. Okay, so we will skip the overview of the BTC activities in Nsawam. That one is so antimicrobial resistance, being the silence pandemic. What can we say about it? We had discussion yesterday.
So I think one of the things he said was that we hear of pandemics, COVID and all of that, but this one with antimicrobial resistance is not something that comes in the news, but the way it is, it's killing a lot of people. There is data to support the number of people dying, was associated and all of that. So for starters, we call it a silent pandemic.
Is there any other?
That was given by farm Mauna. Okay, so you give us an overview of what is the silent pandemic. You also give us strategies that we should put in place to help curb the pandemic, the silent pandemic. So that's what.
Please, any other?
Also, I think there was a projection asking if care is not taken in the next, let's say, 10 years, what would happen in the next 20 years, and then overall the financial cost is going to have on the hotel.
Please, any other?
Also made mention of how the food that we are consuming, the fishes, the meat that we are all using antimicrobial. In a way, we are also, so whenever we are taking those meats, those fishes, we are also taking antimicrobial. It's being in our system.
Okay.
Also, like that there has been antimicrobial remedies. You don't protect what you have. You are going to go back to the era before antimicrobial resistance. So we heard about the One Health. That's what we should have the presentation. That is the human activities, environmental activities, the food and the fishes.
Okay. So our next discussion is the drivers of PMR. What are some of the drivers?
Since I sent you the slides, no. Since I sent you.
Okay, I'll take my environmental discharge. Environmental discharge is including our agri sector and that of our hospital, healthcare, and wastages. Okay. Any other?
I think she talked about antibiotic. She talked about IBC and blue vaccination.
We also talk about behavioral gaps and knowledge gaps. Yes, as in sometimes people lack the knowledge, and so more education has to go to reduce the.
Okay. Any other? Any other? Okay, let's go. The low prescriber knowledge to all of these advice. Okay, we also discussed the relation between IPC and AMS. Right. And it was discussed that it complements each other. Because if there is no IPC, there will be an increased level of antimicrobial resistance. But there is no, and one thing about IPC that plays a major role in the resistance is hand washing. So let's take it. How many of us have washed our hands this time when we entered the facility? Hey. IPC coordinator, you wash your hands. I expect to get on the house. I'm not entered everywhere.
Yes, also a team.
I'm posting a video.
I saw
you in.
Don't defend.
IPC, I'm not even you watch it tomorrow. IPC,
Okay, carry on. Doctor, so can you tell us something about the laboratory networks? Laboratory networks.
That one, it was a bit complex, but then we agreed that there are platforms that we are supposed to enter our data every now and then, which we look at the offices.
Okay. Then our final one was on antimicrobial consumption and use. Dr. Sai,
So that one she was saying.
antimicrobial consumption and use.
Consumption.
Okay, let's clap for ourselves. Okay, so we'll start with today's presentation.
Okay, before the
Direct-
finish
okay.
presentation, I don't want to ask a question, but I want to ask a general question. One thing that I want to raise is one health, yesterday for instance was the first time that I am hearing to that level. What is then, what is headquarters doing to bring this down to us? Because when it comes to our level, for instance, the assembly, for instance, I want to talk about the environmental ministry, the veterinary service, ministry of health, and other stakeholders. Dealing with them is sometimes difficult, and for them to use to understand this one concept. So I don't know what the health service is doing. And this one is even a session of the business IPC, ETC, more or less IPCT, but others and then other facilities. So I want to find out this one before we do that. So thank you very much.
All right, so this is a direct question to you, so I have to answer it directly. All right, so I've been thanking very much. Once again, we comment Nsawam Hospital for the good work we are doing. Interestingly, I have a special relationship with your nurse manager. A young lady of that man. I've known her as far back as 1999 at Kimberley Hospital. She was then a very beautiful young lady. She is still beautiful, and a very handsome young man came from the hospital to marry her but we've remained in touch throughout. So she is one of the reasons why we brought
program.
All right. So I think let's begin with the question just asked as what we are doing. So is it that is the approach the whole world is using, like I said, One Health approach. And that is the underpinning principle for all AMS activities nationwide and globally. And not even AMS. What is the origin? Come again?
It's a origin.
No, there's okay. The animal, there is a one. The animal
Bats.
is bats.
Yes.
Bat ideally doesn't lie within the stock health. More or less with animal health, with veterinary. But you see, from there, it can easily now find its way into what? All right. It's one of the so-called zoonotic disease that is plaguing us. Anthrax from cattle. All right. So ever since the world saw that, they now see health as one. One health is not divided. So whatever the veterinary does has implication for what we also do. What is done in the agri sector, like this insecticide that is used in spraying vegetables. If you poison them, finally it gets to us. And many hospitals have reported a lot of food poisoning emanating from the poisoning of what they call it, vegetables. You get me? So at the ministry level, when it comes to it, it's not being done. We have an AMS secretariat, an antimicrobial resistance secretariat, okay, or AMS secretariat, okay. That involves those of us in the health ministry, Ghana Health Service, CHA, whatever. That involves those from the veterinary ministry as well, those from EPA, environment, and then those from being plant medicine, and then food production. So the One Health concept, when it comes to addressing AMR at the ministry level, has this body constituted. And they come to the steering committee that oversee all AMR activity within the country. So like the lab a gentleman spoke about yesterday in relation to the veterinary and whatever pathogen that they are able to identify, whatever isolate they have, they put it to the AMS secretariat at the Ministry of Health. In Ghana Health Service, what we are also doing is to establish an AMS steering committee, which is made up of all the key divisions within the service that manage medicines one way or the other. It begins with health promotion division, because we are talking about variety of medication. It has ICD, all right, which has, of course, all doctors, all those who are there. It has nursing division, which has its IPC, whatever I can think of. It has laboratory services. Dr. Papa was saying yesterday, and pharmaceutical services. All right. So this body, for us, that's our tripartite committee within Ghana Health Service. That's the steering committee overseeing AMS activity within the service. But we intend extending it, so we can also rope in maybe the municipal assembly, environmental health, within health service delivery in the Ghana Health Service. So that's what we are now doing in relation to approaching AMR using the One Health approach. Are you okay with that? All right. The second issue I also want to touch on is what you raised in relation to the Sustainable Goal indicator, which addresses AMR. So yesterday I looked at the World Health Statistics, all right, and it came to the 2004 report. It came to the fore that there is an indicator, which is the indicator 3D2. I think we all know that the indicator 3 talks about improving what? Health, wellness for all. Okay, and the target 3.8 talks about achieving universal health coverage. All right. Now, the indicator 3D2 measures percentage of bloodstream infections caused by selected antimicrobial resistant organisms. Percentage of bloodstream, so that's what the world is now monitoring. The percentage of bloodstream infections that is caused by selected antimicrobial resistant organisms. And that data actually is placed in UNET. The lab does that. It's placed in UNET. All right. So that is what indicator the world is using to measure AMR resistance global under the SDG. And I think the third issue I also want to raise is the fact that the antimicrobial pipeline was running dry. I think somebody mentioned it. You mentioned it. All right. When I went to, yesterday I had something in mind, but I wanted to be sure. So I had to confess. I had to do my research properly before I say anything. I know you people are intellectuals. They're saying that you better check and see whether I'm correct or not. So I checked from two sources about how much does it cost to produce a new molecule. Checked from two sources, and I want to bring it to attention. So the first source indicates that, say that research and development activities drive competition in the pharmaceutical industry, and the cost of developing a new drug ranges from $150 million to $1.5 billion. The cost of developing a new molecule ranges from 150 million, not anesthesia, $150 million to $1.5 billion, and the process can take up to 10 years. Yes, just for one molecule. Another book told me that it ranges from 84 million to 848 million, and can take up to the same period. So just tells you, it gives an idea of how much it costs to develop a new molecule to combat antimicrobial resistance or pathogens. All right. So on that note, thank you so much for your order. Thank you.
We will start with today's presentations. Our first discussion is on hands-on training on points prevalence survey. To be led by Hamilton. Let's welcome him.
Okay, all right. So I would ask to let you know the outcome of the pre-test we did yesterday, and it was quite impressive. The list was 80% yesterday, last month. So we are hoping that by close of it today, we will all score 100%, because that's 20% of the gap that we feel. So kudos to all of you.
I'm back again. My name is Tom Moreno. So this is going to be one of our shortest presentations. I'm hoping. We're going to talk about the GPPS. And because you have done it, I'll say thank you. Unless you want us to do a few things. So I've been hoping we'll be in some groups, and then each group will have a pharmacist. I don't have physical meetings in a situation. So we'll share some documents and then we try as much as possible to look amongst yourselves. Right? There will be nothing projecting today. This is my background for pictures. So that's my background. So we'll share some documents and then how many do you have?
We do just 2 big groups.
Yes, that. Yeah, but there must be a pharmacist.
Outside this here.
We have
One and a half.
So one prescriber, one pharmacist, one lab expert.
Yeah, only one prescriber, one.
So we have to
No,
discuss.
no, sorry,
Yes,
is that a nurse prescriber?
yes.
Are you a
Next question.
Nice
Special.
prescriber.
You have 4 nurse prescribers.
Okay, so how do you do the
The doctors
so what's the team? What's the team for the same? Which
Which
one do
there
they
is of that are
Two pharmacists, PNT nurse, a midwife.
Okay, so to make it easy, in your 2 groups, make sure there are people who are
who have been involved
yes
in
in those
this.
groups. So we can just share document.
We can do it
So
round
one,
Then,
and we have two psychiatrists.
round table.
The chance.
Let's share. Let's share. One big fine. To make it easier. Yes, that's fine. But I mean, we'll just try and share. The documents are. You've seen it, so.
No, I'm sorry.
The thing is, it might not fit everybody.
You know, I'm sorry.
Each row will have one.
So we can print.
No, there are some samples. We can print. So you don't need to print. You don't need to print.
Okay.
Some people will still know.
Each row will have one. The back row has more than one line. But you can. It'll be a discussion, so you stop and you pause ask your question and continue, because we'll be there. There'll be no official ceremony, so then you'll be asking. There are different documents. When I call them documents, then you put words in them.
don't connect internet.
No.
Only one. You can see the
There's more.
So the
And you were wishing that you have more of this, but it didn't reach everybody. But at least each
you
group
just
will have
complete it.
this.
So that I read
Three things, three documents. The wash, the units, and then this one I'm sharing.
This one, I can hold on to this one. The protocols. We'll leave it for the
These
house.
are protocols, we leave it with you later. So, clearly the two, the unit form and then the wash. You need your
So if we're ready, I'll make it as complex as possible and confuse as many people as possible. So that when you do the survey, you are speaking to the facility, they will appreciate what you are doing. Because I you collect, you're going to validate. That's a very complex process. Whoever is doing the data entry, and then it comes to queries, you can fix one, then you have more programs to go and fix, so it takes a long time. Just so that they might want to give you some money or respect you when you do the thing. I'll make it very complex for them to don't get it. So you have an AMS committee, and then you have an action plan, and you're doing certain interventions. However, this helps because then in your baseline you see where you are at when it comes to procurement habits. That's what this one does. Like I said, very easily you assume that we're doing fine. The doctor is my friend, does his best. Right? I mean, all those things. When you do these things, he exposes those areas. And then he identifies gaps that you can focus on to train. I mean, you can just do trainings or cruise programs, not so the problems are. That way you get impact as opposed to doing generic overview of the issue. So about 2006, the European Surveillance on Antimicrobials piloted the protocols we have. And then 2009, they joined with the British Surveillance on Antibiotics. So the EU states were using this protocol. So it is run by University of Antwerp and Belgium, essentially. And then the protocol helps us to assess prescribing habits at both inpatient and outpatient departments. So some in Ghana we started using it for some people for 7 years now, some people in a few years. The OPD model that we did the last time only came in 2023, so that's about 2 years ago. It's a never changing protocol, very simple, it's free. So there are updates over the time. And since you've done it, I think you appreciate that you felt it was not Ghana friendly at some points, but as you continue to do it, you're going to adjust. And you didn't change the protocol, but then you change how you approach using the protocol. How did you do the OPD? This one involved. How did you collect data?
I started using the games not too long. So on the 4th of February, after the close, maybe the next day, we just printed out all OPD attendants. And then we used those who actively to fill the forms.
Okay. So that's how you did it?
Yes.
Did you get all the information there? So the doctors put everything inside there and how do you call it?
So we have the client's name and their games number. So I just entered that on the games and then it opens a quickly for that day, for the 4th of June.
Okay. Okay, we'll change a few things going forward. It will make your work easy, because that saves the troublesome process. Was it not? Yeah, the OPD one. You see, you are okay. So I'll define the global point prevalence. That's GPPS for some of us who might be into it. So what we do is that we go and collect some data on the ones that documentation data. They are first a snapshot of what is going on at the facility. At the inpatient department, you involve patients who are actively on antimicrobials. So it means that if they are discharged in the morning Wednesday, they are not part of it. If the plan is yet to be done, they are not part of it. Those who are on. So by 8 a.m. in the morning, those who are on you exclude weekends. I advise you exclude Mondays and Fridays because they are too close to the weekends. I'm saying because in some baseline study areas, we realize that there's a lot of things that go on over the weekend. Most facilities don't have specialists on the weekends. And yes, or senior clinicians on the weekends. So Monday to people are now warming up from the weekend. Friday to people are either at funerals or have started the weekend. So for quality data, usually from Tuesday, Wednesday, Thursday, YPD. But for OPD, any day of the week, it works. So that's for inpatient. I'll do them from times. I don't come and do. So I'll be saying OPD for outpatient, IPD for inpatient. So I won't be, because it's similar. There are two different things we're talking about. So the challenge with how you do the OPD is that you are supposed to spend 4 hours collecting a patients will come within 4 hours of your survey date. So that if you are going to pick, I don't know whether you're going to pick from, say, the morning to, or maybe the whole shift in the morning or the whole day. It's difficult to get that. It's a survey in real time. So it's neither prospective or retrospective. You're doing it as it is, or maybe it's prospective as it is going on. Yeah. So the first challenge I identified with the system is that then I wonder how I'm going to get a data like that. In some places, the then workshop. What we do for OPD is that our auditors go and sit. We have to dial
On the not at the same level.
I think the AMS team understand what we are saying, but I'm thinking some are lost. Please, am I right?
Yes.
I'm trying for you. So like I'm saying, kindly stop me when there's not going to be a PowerPoint. All that is there is that if you cannot be mentioned, it cannot be improved. So let's not expect them to present it. That's all the slides I have for today. So try, stay with me and stop me wherever and then I'll come back. Right? Okay. So where are you lost so far? You have questions now.
What is it about? What are we using it for in the first place?
Okay, I should do that. So it's a cross-sectional survey. And that measures prevalence. Prevalence is how much of the issue. I'll try and get English to speak because most of them are technical things.
Just to help you out. Please, how many of you know about the RUFS survey we do? RUF, National Use of Medicines Survey. How many are aware? The nurses, please, do you know?
The results, we know about the results. When they come to present the results.
That it measures how rationally we are using our drugs. The pharmacy does the survey and they present the results, so we know if we are going overboard with injectables or antibiotics or we are not recording the vitals. So this is another survey that is one to measure rationally the way we use medicines in general, not antibiotics. by general medicine. But this survey is targeted towards antibiotics. It's a survey we've not been doing, but now that we are focusing more on antibiotic resistance and antimicrobial stewardship programs, it is important that we do this. This is key. If you don't do this, then you don't even know what the problem is. So this survey is key in establishing AMS activities or stewardship, together with what the lab will do, the continuous surveillance. Without these, you can't really effectively measure what is going on and how to improve it. So I think you can carry on from there.
Thank you. Thank you. So the objective for the survey says prescribing patterns or habits. And we're able to also, and it's a standardized form. We're talking about standardization since the beginning. So the data you collect, because will be standard, you can also benchmark against facilities of your type. Are you a primary care facility? So primary health care facilities, and who have also used the survey. A number of countries are using this now. Right? The minus the USA. Some other people have their own protocols. So this is what the EU is using, and most of us have joined to use. You're able to benchmark for countries. So you can see Ghana's data. You can see for Africa, so the region. Then you can compare against Europe also. So you see there are indicators that the protocol will be identifying across all the across the COVID and IP. So that's to benchmark. Helps us now identify gaps for focus trainings. So if you are falling short somewhere and you can focus it and try to fix or make interventions to that regard. So that's what it does. You assess your prescribing habits and what is complementary. It gives like a standard form so you can get reasonable results all the time. So that's what the whole thing is about essentially. So it's prevalence, right? We'll measure just prevalence. There are some definitions you see inside going for it. One should be the denominator, for instance. So when you do the IPD, how do you do that also here? The IPD.
On the same day we arrived at the maternity unit, all of us. So we went there. We didn't have yes, we didn't have for any patients, so we used their phones. Then we all signed.
For some reason I miss the folders. I don't know. I'm not saying we shouldn't move forward. I'm an old soul. How about the one before? The reaction is valid, but I won't tell you why. So, what happens is even data collection, we do the paper form collection, right? It's the best. Some people think that we can do the online direct e-commerce. So we do the paper so that you can refer to. In our experience recently, when we ask, oh, what data do you have? They said, oh, let me just go on, we don't have any data. So I mean, paper, at least, they can't take it from us. So that helps. So you go in the morning, but usually, what we advise, you do a team prep every morning. Because you can assume that the quality of the collection also really matters. When you're doing the validation, you see that there are some things some people missed. And then it becomes a problem, you have to go back in. So you want to prep in the morning with your team. Of course, not everybody is involved in the PPS collection. It's a number of people. And also, it depends on how many wards you are involved in. The beauty about this is that when you're starting, you want to start within what you can control. The whole AMS concept. You can't do everything. So there are some facilities that we're doing IP, some of them OP. Polyclinics didn't have wards. They couldn't do IP, so they didn't only OP. Before that, we were doing the prescription audits. It's a simple Excel form that I developed then. This like the RUM. Because pharmacy, I think once a while you should share how you do some of these things, and they appreciate the data, like I'm saying. So when you understand the RUM, they get a picture for the PPS. So we prep in the morning and then we move. the idea, because the point prevalence survey, it means that it's one time. So if you go to this room, if this is Ward 1, and we enter Ward 1, you must finish Ward 1 today. You won't leave it and come back. Right? You come back, there were so many problems, so many misses. So point prevalence, one time. So if we have 4 wards that we want to do the previous for, and we think we can't finish in a day, we do 1 ward at a time. When you finish in the next ward, you don't come up to this ward again. You don't chase patients and say, oh, someone will be moved in 5 minutes or in 2 minutes. So whatever you see when you were there is what you focus on. That's all. So if you can use a number of days, but also let me do from Tuesday, Wednesday, Thursday. The data is quite quality. For the weekends, I mean, I think the same thing here also. In holidays also, so you plan on days where you can get Tuesday, Wednesday, Thursday, so do the work. So you go and then you pick. Right now we'll start with IPD. Look for the unit form. In the forms you have IPD. You can show it to me, then I confirm that you have it. As I say, the OPD one knows, right? Outpatients. This is outpatients. That's outpatients. Also outpatients. That's a word form. That's it. So word form, yeah, that's IPD. So how many people have the word form? Yes. You can take out the statement because we use all the documents inside. So how many people have the word forms? Let me see where you have it. At the back, so that line you're using. Words. You don't have it. Yeah, with me. No. I don't have it, but I will. You can take out the statement and then isolate the form. You have it. Yes. What form? Can we continue?
There are more words if you don't have.
Okay.
There are more. So we'll continue. So if you can see the word form, then it comes with the dates of the survey. So this form will be one for each room that you enter. So if you have how many wards do you have? You have 7 wards. When you say 7, you mean rooms, or you mean maybe like maternity blocks. So you have 7 blocks. And each block has how many, for each patient? Each block has how many wards? How many rooms?
Well, they are not really separated.
Depending on the ward.
So you have, if internal medicine, for instance, you have male and female ward all in the same space.
No.
So I need those details so I can help you with this one. That's what I'm asking. So I need like those specifics.
Let me see.
About 3 cubic.
I should have seen it.
3 ward has 3 cubicles, and then 2 VIP rooms.
And one isolation.
And one
So when you say cubicles, you're saying something?
Yeah, so male ward, for male ward, is both medical and surgical.
Okay.
And the female ward is also medical and surgical. Then we have the maternity block, which is divided into about 5. Gynae, obstetric triage, we have the HBB, we have the labor ward, we have the hand, so that is the whole block. And we have new also at the maternity, but now it has been, the place is being renovated, so it's here. So we have NICU in there, we have recovery ward, we have ICU, we have emergency, but mostly we don't capture the emergency. I think the last time we captured. And we have the children's ward, we have the pediatrics. So the main wards are the maternity, the male, female, male surgical, medical, female surgical and medical in children's ward.
Okay, so that's a picture you have.
Nursing.
And I see,
Yes, I
that's
see.
sure. So you create the ward names already
Yes.
on the plot. You've done it on there.
Yes.
I'll have to take a look at it maybe after. So do you have medical ward and surgical ward in your forms? Or because you are showing me mixed wards now.
Yes.
I
So
don't
we have allocated beds for surgical cases in the main ward. Like if they have 5 beds for surgical cases, then maybe the rest, so if they have like 30 beds in the unit, 5 has been allocated to surgical. So it means the 25 will be for medical. That is how we did it.
Yeah. So you're using a lot of mixed wards.
Yes, we have this ward.
Beautiful. I mean, I'm happy I'm here because then it shows a different picture from other facilities where they would have had a surgical department, like surgical, or maybe male or female. So that one, what happens is that you call it surgical ward, like surgical, ASW, adult surgical ward, and then you have those ones. But because now you have mixed, that's fine, it works anyway. So the dates of the ceremonies and the person's completing. The auditors are going to be those who are taking the forms. If I didn't define auditor, auditors are just those who are taking the GPPS team that are going to the auditors. Hospital name, then an award name. So the reason I was asking for the type of what you have is that you are going to work within 3 activities. Activities are medical, surgical, or ICU. So when I keep saying activities, I'm talking about medical, surgical, or ICU, right? So over there are the type of words you have, and then that codes, right? So adults or pediatrics. So AMW should have been adult medical ward, ASO would have been adult surgical ward, and then pediatric medical ward, pediatric surgical ward. So depends on. So whatever ward you go to, then you choose the corresponding code for that ward, right? So whatever ward you go, just take the corresponding code for that ward. And then actually there's a mixed ward, yes or no. So the mixed wards are the ones that have both medical and surgical cases. Usually, we were seeing that a lot at the OBGY, where they were having surgical and, SVB, CSP clients and all those ones in the same place. Whether it's for bed capacity or bed design, the protocol allows us to do that. So if you came into this room, Ward 1 for instance, and it is adult medical ward, for instance, and it's mixed, you are going to have, you use mixed. And you see at the activity level, there are some 2 boxes, some 6 boxes, and activity, you have a medicine, surgery, intensive care. You can see that. Yeah. I spoke about denominator. So you always start with the word form. So for this one, it's for each word you enter, or each room you enter. If there are cubicles in the room, and then you want to consider them as one room, that is fine. There's no problem with it. So for each room you enter, so at the end of the day, you are going to have one word form with a number of patient forms for one word, right? I spoke about the denominator. If we are going to calculate prevalence, we need to know out of how many have an infection. So we count all the beds in the room. That's our denominator. Right, that goes into total number of beds. So that goes here. Fortunately, you have allocated surgical and medical beds. It makes your work easy. Other places they have this. So they have 20 beds. And then when we went there, 3 are surgical cases, 7 are medical cases, some are empty. So it's difficult to allocate. But since you have done that, it's easy. What it means is that if there's a bed there for surgical and it's empty, it's for surgical. Is that the point?
Yeah.
Super. So then you record that for surgical. In the same room, you can have, if the total number of beds was 20, and we have 15 for medicine, we can have 5 for surgical. Empty or not, whether someone is on the bed or not. Now the other one goes for number of admitted cases at the time you are there. So we can have 20 people in it, 20 beds available, 17 have been admitted. Whether or not I'm antibiotics, once they are there, they become they are admitted. Once they are there, they are part of the cell. But if you miss this data, you cannot do anything. Case in point is if you report that there are 10 beds and you have data collected for 12. By the time you enter 10, you shut that area for you. You've done that 10. So if you have people on the floor, count them as bed. Otherwise, you cannot use them over there. That's the point. And that's how you can measure prevalence. Again, if you miss that place, you see that when your data comes, you have 100% prevalence. And it's not possible to say that everybody came to Nsawam Govt also had an infection. Right. So then, those small things you want to look at. That's for the ward forms. Now, because you are doing this for the first time, do the simple model. The HI model is a little complex. You can see this HI. Yesterday we spoke about cannulas and catheters also being. So we can. You see, HIs by definition, and essentially here is that patient came here after 48 hours, they have a new infection. That's an HI. It's like aspiration pneumonia. Yes. So if the person came here with one thing and then gets another thing while they are here, then those are also acquired infections. I think some of the data points for the facility will record those things. Surgical science infections, so that also comes inside it. So I want us to skip, otherwise we'll have been recording that also. I want you to enjoy the protocol so that you want it often. When you pick the HI model, it becomes a little more complex. Not even from the paper collection, but from the validation. Because you'll be demanding too much of you. So just focus on the simple one. When you go on the site, there are different types. The simple model, the HI model, or the OPD model. So just pick the basic and then life will be easier. Any questions about the word forms?
So for instance, on our ward we have 30 beds, but with one of the wards, I found out that about 7 is allocated for surgery and 23 for medical. But sometimes the medical cases are more, so they occupy the surgical beds. So in this case, if I've entered that on the EPS, then I'm entering more than 23 cases of medical antimicrobial use. Will it shut down, like you were saying?
And if you allocate 23 beds to 27 beds to medical and 3 to surgical, when you complete the 27, you can't add a medical case as surgical case. We'll flag that error.
But it happens actually.
I would think that in that case, this man, maybe then you can either validate or. So if, let's say there are 7 surgical beds, 23 medical, but on that particular day there are 10 surgical patients on the ward, then you probably, at the beginning, the number of beds, you indicate 10 surgical beds, so that the 20 will now become medical at the beginning, so that it will allow you to enter the data.
So that means
every day it can be
On the day that you are doing it,
yes.
When you say they are moving 7 days, not every day.
7 days.
That's why he says a point. So on that day, what was happening on the ward?
You see, and in fact, you are going to do the paper forms before you start studying. You start creating the forms. Because you have to it, when you want to press save there, you don't put it. So you can edit it. Then you do that. And so every save will allow you to edit it. Every saving, because the dynamics might change. So maybe new words are there, you have included new words. You can decide to say, okay, this save we're not doing here, no pediatric here, no adults here. Just focus on what you can. So when you begin to appreciate the protocol more, then you expand. You have skill points, and then it's a bit demotivating if you do big thing and it doesn't work, and then you're like, it doesn't work. But if you started small, if you decide to do even one department, some of them interventions we've done across cities of AMS. There's one called the contract prescribing. You've seen it. The delayed prescribing. Oh, okay. So one of the things, and when it's talking about your REM antibiotic use of the OPS and then some of those interventions will drop it. For 2021, I think Lekman was a key for Accra. How they are dropping below 20%. Around there, about 14%, 15%. And the best about that one is when that you sample 30, they sample 300. You sample 100, they sample 300. You know, the more the size, the more accurate the. So, I mean, it's possible. It's not like it's not just 5%. It happens. Okay, so that's for the word forms.
Sometimes on the ground, some word might have over patients, so it's transferred to, for instance, when you go to maternity, you have lying ward, and then you get a patient and you have to move to gynae ward. So, and the case of the point of you taking it later, won't it affect the word of information?
Because you control this one, you're able to address those, and the solution you gave was perfect. So if there was a spillover in certain words, you can allocate them as a single word. Right? You can decide that, okay, so half that side, that gets a new word form. You see, you can have 5 adults medical words, MW1, MW2, MW3, you have OBGY1, OBGY2. You are creating as many as possible. So for the accuracy of your results, you do that and then you fix the problem. Right.
Let me ask one question. On that day you did the sample, the intensive care unit didn't have patients, but they have 3 beds. And when I spoke to the child, they allocate one for. It can be the cases they have can be from any of them. It can be pediatric, maternal, or male, female, like it can be any of them. So on the system I allocated one for like surgery, medical,
for ICU. ICU is an activity.
So it should just be 3 for the ICU.
If it's ICU, it's just intensive care. There's no medical surgical. Once the case is in ICU, there's no that activity is ICU. It's no longer medical or surgical, no, it's ICU. So if you have recorded it, then you don't get any data, you just write the number of beds and you leave it there. Then so it asks your prevalence. But if you avoid the ones that do not have those patients, you are seeing that everybody came in fine. So if you record, I'll show you a dummy results of the OP, then you see that it will record it at 100%. Okay.
So the statistical analysis system that has been developed, or is a software that is developed for this summit. I look as if it looks she's far ahead of us, so I don't understand certain principles that you is talking about. That's what I'm asking.
I'll try my best to bring all of us to speak. I promise that I can bring us to speak. I'm just saying because they have seen it. That's why the conversation is prepared. It's hosted by the University of Amsterdam in the beginning. So it's a European protocol that's we're using. Right now, all of us are using it. So we upload data to them, we analyze data, and then they send the feedback to us. It makes work easy, actually. But I should mention, ownership lies with you. Anyway, so I remember, so there are a few facilities I created whatever for them. Before anybody can access the data, they have to write to me or whoever is the admin to okay it before they can use the data. Because currently there's a manuscript out with some of these ones. And so without them coming, so you have a local admin, which I think is you. Well, an administrator.
No, I can't say I'm the administrator. I actually speak to one of the, we had a training last year, and so I speak to one of the AMS guys who is working in the facility. It's not here.
Boss, then you swear in I mean, that's what it is. Yeah.
But can I ask another question? I want to find out if you can enroll the others in the system.
Data entry.
The other members of the AMS.
Yeah, that's you want to help with the data.
So you can help us.
No, she does with the no, she needs help to do the enrollment. So I mean, yeah, that works.
Can you speak about the call people to do the survey? So, and then when they're doing it, not to share the words, like they should do it as a team. You get it?
Yes, that's what we did.
No, so where she's coming from, there are some people that, you know, and they're begged to finish quickly sometimes. One person will take the form and go inside. Did you ever experience that? It's only as you tell her the truth.
They went as a team, but some deserted. Some deserted, so the team.
It's a valid, yeah. So when that happens, I mean, the whole EMS thing in itself, you know, putting the structures together, they will see on paper that they should allocate time off work for those things. I don't know how you put the content here, but I pray strength for you. Most of us don't know that, yeah. We don't. That's Tel Aviv. That's how it is, unfortunately. So, but I see, I want you to be able to achieve some of these things and see you have a little more passion, that's your motivation to be easy. I mean, if it's the beginning like this, there's an initial, when you push the ball rolling, you get to appreciate some of these things, you know. So you have, I used to do data entry for 1 a.m. because I had to finish work, whatever I do. And I can't do data entry. So, I mean, and it's not like 1 day, and then when the data comes, I'll show you a feedback form, and you have to summarize and write a report on the trainings or dissemination. Another extra work. So I don't know how you do it here. I'm praying for you when I leave.
Please pray for us.
So the point I was making is there are 3 core people who should do the survey at each point, and they should move together. Don't let the pharmacist go to this ward, the lab go to this ward, so that you finish it. When you do that, it affects the result. You get erroneous results. So there should be the lab person who takes care of the lab stuff. Yesterday we were all here. Most of the things they said. We really appreciate it. So we all have our expertise. So the lab personnel will look at the lab aspect of it. The prescriber will look at the prescribing aspect of it, and then the pharmacist will look at it. If you are pressed, like we are saying, and you cannot do everything, just do 1 word for the survey, and that will be okay. So that you can now monitor and modify, and then you train more people. He might not be the only prescriber that has to go along all the time. The pharmacist will train another person, the lab will train another person. So that's what I was saying.
So actually, when we were doing that, we moved in, the whole group went.
The whole DTC?
No, the AMS. So at the maternity, the midwife and the team knows a lot about, so she was leading the team there. So when we went to the medical ward, those of us there also led the team. That is what's how.
So my challenge with that is that all we're doing is, if you are on the medical ward, you don't do medical the DPS. Because you are very good to explain what the situation is. And that will change your results. Now I'm just saying, no, it's human, all of us. I'm not saying that you will do it. I'm just saying that you're very easy to explain. If the misdiagnosis, you're very quick to explain. Because, and the audit, you don't have to. So you see,
It's like
that's key. Yeah. When that happens, you don't get accurate results. You get what could be false positives, and then it doesn't help because then you don't, because the data is yours. No matter how bad it is, it's only you. Nobody can access the data, right? I mean, nobody outside you can access it. No matter how bad it is, but if you have people who, that's my word. At a point, I'm speaking from our experience over certain facilities, or a little small competition. I'm on medical one, it's a pediatric one, and then you go to, you know, to make it look like, oh, we're just young, can I see you are yes, you know, that's how that happens. So, I mean, you can, when I say, you can relate it. So, from the word form, we go to the patient form.
the next thing is
That's to patient form. So the word names that you had identified on the word form will go into the first box. So if you named it AMW1, that comes here. The patient form is for each patient. So if you have 20 patients on the ward, I'm going to use 20 of these ones against one word form. Yes. So the first name is the word name, whatever you have decided. The next is the activity. On that particular patient, because you have mixed words, that particular patient, is it a medical case? Is it SVC? Medical? Is it CS? Surgical? Yeah, so that goes to MS or IC, whichever one. Yeah, over there. The patient identifier becomes their case number. This is for your records, because when you have to validate and have queries, you want to move back to the wall. You can identify the patient with the case number. Right. The next is a survey number. That will be given to you by the platform. When you save, it will give you a survey number. So you can write that there. So in case you are doing your own audit after that, you can refer. If there are queries, you can go and change. Right. So the survey number will be given by the platform. Are you with me? Okay. Now the age, I mean years. If it's more than 2 years, you report the number of years, 7 years, 6 years, 24 years, 94 years. If it's less than 2 years, you record in months, 1 month, 2 months, up to 23 months. If it's in days, less than a month, so 28 days, 12 days, and all like that. And the current weight, you record the weight. If you get the weight for the ones you are doing, you get the weight. The folder. So this is why I like the folder. So the folder time we put their weights for the games. You don't get when it's together.
we've been talking to them a lot of
You know, I mean that's I don't know how I would approach it, but try. You know. So the weights. If you don't see the weights, don't go with the picture. You didn't get this one. If there's no weight there, you don't continue. Yeah. If the weight is there, you see, you want to reduce your interaction with the people in the world as much as possible. The nurse or the doctors. Don't go and ask explanations. Whatever is there, record it. So that when you see how, if you can present data, they understand. You know, there was a time when I didn't threaten drivers, but you know, with RUM and insurance and all, you have to do certain things on the phone that you might not have learned from medical or pharmacists too, but it's in practice, you know. So pharmacy will say, oh, this medication errors. Then they'll say, no, where's the proof? So back at days, I used to take a picture of the prescription, remove the patient name. So clinical means now go and say, oh, and the doctor said, no, it's not true. I said, no problem. And I told them that next time I come here, I'll bring you everything. So take a picture of the prescription, cut off the patient's name. When you put your prescription up there, you can see your handwriting. So you see, it makes it easy because they're like, oh, okay, it's done. I mean, but that was that time. Now I've changed. I gave my life to Christ. So I'm a nicer person. Otherwise, I'll find you a evidence. And also this can be your evidence after when you see the graph, you see that so medical whatever, it's not very good, it's not very good, and so that happens. Now if it's a unit, for units only, you record the stational age and then the units. You can see that on the form. Then the sex is male, female, or unknown. I don't know if they have unknown.
There's now two sets.
Yeah, I know two. Let's go to not Trump.
He says there are two sets.
Then go to not Trump. Boss, they're not Trump. So the next one is a treatment based on biomarkers. So I think the routine here is that we'll do the full backgrounds. Right. And then that will inform us to initiate treatment on it. So we can see over there. So whichever usually the white blood cells counts. I'm presuming that the describers you use. So you tell us which one it was. If yes, white blood cells. Which specimen was used, large, urine, whatever, then you indicate the sample over there. Right. Then the value of the you see, also depends on the time because it's a point prevalence survey. When the patient comes and is on the ward, you might go at the place where the culture was requested but hadn't been done. So that might not be your biomarker. Right. So even in the old forms, we're not even using the white blood cells. If you have the old, when we were doing PPS those times, there was no, we're not even using white blood cells. So we want to see whether there's a culture that was done. Now this is over here, so now you record. So if you go there and then the patient had been requested and the results were not there, it's not there. It doesn't mean that it's not being done. Because there's a place that asks for whether quality sends the lab after. So what sample was taken. If you are there when the cultures are there, that's fine. I can speak on some authority that about 95% of our treatments are empirical. You see it on the targeted. Patient couldn't afford whether I was requested or not. It's something, so it's always going to be empirical. I'm talking about on the PPS. If the results come, you can now advise change. So, whether the sample was taken to the lab for cultures, yes or no? If yes, what sample was taken? Is it blood? Is it urine? Is it stool? Is it bone? Whatever. I think I almost skipped the. So over here, you're going to record. Here, can you see? You record the value of the white blood cell count and the units. Over there. Now we go into any questions now. Okay, you'll be looking at questions. We'll fix them for you. Then we go into the treatment, antibiotic name. So several boxes for each one, because some people might be on 5 antibiotics for some reason. So the name of the antibiotic, so say amoxicillin, and the name of the antibiotic. We're focusing on the anti-infective agent. I'm saying so because there are some instances where we have a combination amoxicillin, clavulanic acid. Only the amoxicillin is the anti-infective agent. Ampicillin, azobactam, or piperacillin, so those ones. So only the. But if it happens that it is ciprofloxacin, tinidazole, for instance, the two are there, right? So you're able to choose and then you can use it. You're with me. Okay, so the generic name, so amoxicillin. So you are still going to write amoxicillin anyway in the form. So what happens is, what's the strength of amoxicillin 1 gram? Like about 875. 625 about 500. 1.2 is about 1 gram, and that's so then whichever one it is you put there. So number 1, amoxicillin plus clav. Number 2, metro. Like continuous. Now the start date of the antibiotic. Right, the start date. So we went to the ward 28 July, but antibiotics were started 26 July, for instance. There are sometimes it's for 2 weeks. sometimes for so long, sometimes, but I mean the conditions will tell. If I don't think we'll be looking to treat price under 21 days or typhoid or so under 14 or 10 days. So I mean it's allowed. But it also now measures duration of, so you see, because we're taking the data and the results we see, we can even see average duration of therapy for some of these antibiotics. So start date goes there, and then the single unit dose. Is it 500? Is it 200? Is it 300? So you record just that over there. And the units of the dose. Is it milligrams? Is it micrograms? Is it grams? Is it kilograms? So that recorded that also. The dose per day frequency, 2 times a day, 3 times a day, once a day, 4 times a day, you record that in the corresponding boxes. The routes, is it parenteral, is it oral, is it rectal, is it inhaled, you record that also over there. Okay. So you see that
The antimicrobial is anti-malaria and antimicrobial.
it's an antimicrobial, it's antiparasitic.
So you capture that.
So you could, but very easily, like I said, to start, do antibacterials, forget antifungals also. You could, yeah, but yeah,
But
let's do that.
The heading is antimicrobial, that's what I'm asking.
So as I said, it is also captured, but you want to do what you can work with.
Okay.
If it's too huge, it becomes cumbersome.
Okay.
Right.
It's antiprotozoal. It's not an antibiotic.
Well, antibiotic, yeah, protozoal parasitic.
It's antimicrobial, but it's not an antibiotic.
Yeah, I'm talking about antimicrobial, it being an antimicrobial. So we captured those ones inclusive. So since he's saying that we should rather focus on the antibiotics, that's okay.
No, it's
I use the data.
It's, you see, I would, if you had done the end, you'd be able to relate to these things. You want to keep it as simple as possible, and then you keep going. But if you do everything, and we didn't start with everything. We just did some, but just some, then continue. Right now, on that point, yesterday, when we were doing consumption, we spoke about some of these things. And you see that we don't focus, we focus only on that for systemic use. No topicals, no, those things. Right. That's for the DED and the ATC. This one will use the ATC classification. No topicals, so you have no business looking for rinsing cream or those things. Just focus on the ones that are systemic. Alright, thank you. Diagnosis. That's where we start using our appendices. There's appendix 2. For further explanation, before you go to appendix 2, there was this, right, underneath the patient form. So it helps you to, it clarifies better every point and what information you need to provide. When you find the appendix 2, have you found it? It's 2 pages. That's diagnosis. This somewhat standardizes our diagnosis for us. You'll be writing very long diagnosis. There's a coding for it. So, anyway, okay. So if it's a CNS infection, whichever one it is, you really write CNS for diagnosis. If it's an eye infection, don't specify what it is, just write eye. So it helps us to standardize. Otherwise, it would have been very cumbersome having to analyze the data. So this categorizes it first. If it's ENT, whichever one it is, just ENT. Only otitis media was taken out of the So AOM is acute otitis media. Respiratory, if it's a lung abscess, whatever, lung. Acquired tract infections are there, RU out here, and then bronchitis, pneumonia, COVID-19, TB, and all those ones are inside there. OBGY, all those ones are there. So those ones record the diagnosis for us. sometimes it won't be, will be prophylaxis. So yeah, false as that one also. There's a prophylaxis for skin infections, for surgical infection, all these ones are there. You find the prophylaxis over there. Am I with you? That's for diagnosis. Type of indication, that is appendix 3. So over there we see the community acquired. If they came with the conditions from the house, community acquired. If somehow, some way, we gave it to them, hospital acquired, right? And even that one is in different levels. HE1, HEI1 will be supposed to break it. So they did a surgery, whatever it will, HEI1. It continues up to surgical prophylaxis. Should I run them one by one, or we can just talk about them? You get it? So surgical prophylaxis is a single dose. We see this a lot with that. You see SP1 for Senidazole, for instance. Then SP2, especially for, okay, so if SP we do 24-hour IV, that's the, sorry, CS I mean, you do 24 hours, so I'm also 3 times a day would have gone under SP2. If it's for more than 1 day, it's SP3. Those ones, yeah. But I said I also quantify the duration of the treatment. There's also medical prophylaxis. That's overcalled. Then unknown indication. Sometimes you need it if the diagnosis was not stated. I said we don't want to assume, so I'm not expecting that to go to the patient case and say, oh, okay, look at the writing, but I think it's this, so I can record it. There's no, there's no. And it speaks to the quality of the practice. Now, reason.
I was about to say that this part doesn't look as easy as we are saying it. We had a lot of difficulty during the time we were doing this part of the diagnosis.
What's the difficulty?
Some of the codes, we weren't sure when to put them.
If you have examples, you can address them. But we're here, so we're not here, so I mean, you can always be trusted, and then we see how source.
The forms are there, so you can.
I think it's really common sense. I came to do that business, and then.
So we'll take an example when you have any difficulty.
Example. So let's say you've had amoxicillin has been given for prophylactic reasons for a client who is going for foreign medication. So how do you respond? If I say OBGY, obstetric gynecological infections, the patient doesn't have infections. So how do you respond?
Yes, madam. My tea is also.
Surgical prophylaxis.
Okay. There's a question coming in.
To add up to what she was saying, I was thinking that you may be proud to the say you give a prophylaxis, let's say the amoxicillin, a start dose. So if at the time of collecting the data, you indicate single dose. Is that not it?
No.
How it was prescribed.
Yeah,
it's a start dose.
So the prescription was a start.
That's a start dose. It says, what are the odds that you meet the client for the interview? You miss. You miss.
Like,
What are the odds that you meet?
You could.
So, maybe a patient has looked for elective surgery the next day. Maybe a patient has come earlier.
Are they on after?
They wouldn't be
Right. They are not on active antibiotics. They don't qualify. I said those who have been discharged are excluded. those who are going to start ICU, as at 8 a.m., those who are on active antibiotics, so it's unlikely you meet that patient. My point is that if you meet that patient, they don't qualify in your criteria, in your exclusion criteria. Right. So are we going? We're almost done. So reason in notes. So if the diagnosis was indicated, then it means that the reason for antibiotic use was indicated. So it's there. So that would be yes. If the indication is known,
they just getting the diagnosis.
but yeah, there's a reason for the antibiotic use. Right. Then guidelines compliance. So that is with pharmacy essentially. You compare to your SC. If you have local guidelines, like specific guidelines, you have used them, but then as you actually see that if the person wrote there was a case of, for instance, common acquired pneumonia, and then the prescription is Metro 400 3 times 7 days. Would that be compliant to guidelines? That would be no. Right, so those things there, so you see yes, no. You assume that you see yes, but you find no. And because people prescribe whatever, and yesterday we saw the drivers, patient, prescribers knowledge and all those income about it. The Bible says a lack of knowledge, people perish. So it's all these things. When you do it, you see it. So nobody gets 100% for. Although you did the survey, you find true or false.
So we are supposed to compare all the diagnosis to the standard.
To guidelines, oh, but I'm sure you see very some of them you can report from memory. Right.
But we didn't know that was
So what were you comparing to? How did you get the consent? We hope your knowledge is there, so I mean you trust the air.
For example, I think we were having some difficulty. Let's say someone at the maternity ward, and she's having dental or something, and the antibiotics came because of that. Okay, any other company, so she's in for of something, but there's another condition, let's say dental. But when you look, and the antibiotics was for the dental problem, but when you look on the appendix 2, even the GI, there's nothing on dental. So sometimes you don't know where to actually get a diagnosis for that. The reason why the antibiotic is being used. So we become confused as to which one to pick. So we are forced to pick like GI and B, whichever is nearest to the condition.
Very easily they will do that, whichever is closest.
So we are forced to put the closest one to it. That was something.
That works. That works. So yeah, closest to it works.
Okay.
Yeah. Even the
Which is the closest to assuming the person had something related to.
So finally I didn't had a dental case before something. Trying to go through the thing when I know.
So through it and help us choose.
Let's find it for you so we can finish this one. So since we're still here, you can catch us. It's not only me. I came with the team. So why I even thought you were asking for, you see, all we've been doing so far, in our minds, you are considering one antibiotic. So the case she asked about, if the person is from OBG or has a different thing, for instance, that would have been a different antibiotic. So note that the diagnosis would have changed. Right. Would have changed. The indications would have changed. So case in point, if patient came in with cellulitis, and that's pneumonia, for instance, you see that there will be CAI for the cellulitis, but HAI for the pneumonia. You follow? So while you were there, patient is on medication for both pneumonia and for cellulitis. If they were on clindamycin, fluclox, or something, then they started amoxicillin, amoxicillin for pneumonia. So you are going to get clindamycin, fluclox for sterilitis. So that will be CAI, right? And then SST. And you are going to get HAI for pneumonia, and then pneumonia, the cold pneumonia for the diabetes.
But say the HAI, what's the waiting period for pneumonia? So the 48 hours, you could read that it's not hospital-acquired infection.
I don't understand. If the person
The
has
HIA is hospital-acquired infection,
Yes,
right?
yeah.
So the person must be there,
Okay, associated.
incubation period for pneumonia.
No, that's not it.
No, I mean, I just wanted to delve inside.
No, if they were here, so how we get CS and HAIs, if they were here with a particular diagnosis, after 48 hours, usually the next diagnosis is also back.
It's not always.
So, I mean, that's what you see right now here.
Okay.
Yeah.
All right.
I get your argument about incubation and all those, but that's how it is right now. So at 48 hours, we consider them. Usually they'll come from things that we have from here, essentially. That's an example.
Yeah.
But unless you have identified another infection that could not have been from here, that would be a CI. Right.
And you know, this is very simple. That is the operational definition.
I agree on the defense. I'll defend my people to the laws. That's fair.
Let me ask non-clinicals. NHIS, how would NHIS indication? You know, NHIS will tell you that maybe if you are treating patient, you have to state all the diagnosis. Let's say 5 diagnosis or 4 about the patient, and then accompanying medication, including anti-antibiotics. So how will this impact on this subject in terms of selecting the diagnosis and what should be antibiotics?
So is it differentials or like several diagnoses for?
Yes, several diagnoses.
No, because it's focused on antibiotics, so unlikely to get multiple, and that's redundant. From very few. In her case, what's about 2?
So I think what you're saying, so when you pick each antibiotic, then you link that antibiotic to a diagnosis that has been stated in the folder.
Now I'm saying that because it's focused on only antibiotics, when it comes to some of those cases, so patient came with a DK, as DVT, as cellulitis, for instance. Our concern is UTI cellulitis. You have no business with DVT and then with DK.
They are going to address that. The insurance, you need to link to the fact that this antibiotic is for this.
For insurance things, I'm not here to push insurance. No, I'm just saying that I thought you were asking about insurance things impacting PPS. No, I can only speak for PPS. I cannot speak for. If the question is on insurance, I couldn't speak for it, but if it's for PPS, I'm identifying that if it requires you to provide multiple diagnoses, because we're doing only antibiotics, very easy to focus on antibiotics. So only when tease out antibiotic treatment and then we assess that.
But for insurance, it's up to the prescriber or the hospital.
But the prescriber will not be at the betting point.
I think what he's saying is that
sometimes when they see second one of the things that is required of them is to come to the institution to verify. That's why it's so.
It's not like that.
So that is some of the systemic challenges we have with NHI. Because some of these claims are processed at the CPC.
Yes. Yes.
And all these clinical details are not available.
Yes.
But you get to see that it's for them to follow and know why such a prescription is emanating from the facility, especially when it's coming from the inpatient. So these are some of the systemic challenges we have
maybe if I can try and link the two. So for the prescribers, for the purpose of NHIS, they would prescribe with NHIS in mind, so they would indicate all the necessary diagnoses that they need to indicate in the folder. At the time of the survey of the PPS, when we go, whatever has already been written in the folder is what we are picking. So when we pick it, for example, if a patient was given 3 antibiotics, for each of the antibiotics, amoxicillin is there, metronidazole is there, something else. So when we pick the amoxicillin, then we follow through and find which diagnosis, which of them, even if they wrote 5 or 10 diagnoses, which of them links to the amoxicillin. So I think that's what we will pick for the PPS. Then we pick metronidazole, which of the diagnoses listed is for that links with the metronidazole, then we will pick it. So the prescribers will do what they have to do regarding insurance, and when the survey is being done, based on whatever has already been written, then we will collect the data and analyze it.
So thank you. Where you have ended. So at the end of the analysis, what will be the information? What are you going to use for? But coming back to the prescribers,
Yes.
to look at, for instance, you gave the example of medication where they have to do corrections and whatever it is.
Yes.
And that's why I was looking at the impact at the end of the day of the survey.
So,
You have gone ahead of us. Or I think he is looking at after we are done with the survey,
yes,
and whatever we see,
yes,
we'll have to bring feedback to the prescribers,
yes,
and we may recommend certain
yes,
changes.
certain things.
And he wants to think how will those changes link with insurance compatibility and all of that.
You finish and then I'll start.
That's what I said, let me
I think I
ask
get
you
you.
a
Now,
question.
are you?
Yeah, I was saying that the impact he was talking about, let's say after everything, you got to know that there's a prescribing antibiotic. Everybody who comes with nasal catarrh or cold has been given amoxicillin. Anyone with complaints of cough, whether the treatment was done or not, labs were done or not, has been prescribed with antibiotics. Then we'll be able to know from the OP that there are certain things, these were the number of people that didn't really need antibiotics. But this particular that has been prescribed, you might not name one prescriber, but who will know who has been prescribing that. Then during the medical coordinator will take it up that prescription has been done for antibiotics has been prescribed for these certain group of people who did not really need antibiotics. They can cut down this them.
Yes, thank you. Then
you see, so in relation to health insurance, form of insurance, they want you to justify whatever you place you get in the folder. So if for one reason you wrote amoxicillin, and later on you maybe added, let me say, azithromycin, what is the justification for those who want to want this? So for PPS fund, you can trace that the insurance was certain as why you wrote both antibodies. Why you wrote amoxicillin fiduciary, then in the course of time you also added what do you call it? Is it justified? You have the laboratory, whatever test to justify whatever insertion needs to be done, which needs to be. That is what insurance is concerned about. But sadly, it's not every time that they will follow up. Once they see true, that's one problem I have with them sometimes. Once they immediately see true antibiotics, without even making the follow up, they cancel it.
I think it explains it's a positive impact on. Is it because it will impact quality of service? It will positively impact them. I mean, you have less errors than you have. So then stop or repeat. So there's this I know that things are written. So they write tablets, metronidazole, 400, 8 hourly. At the word, is it the same?
Yes.
You write the number of these, you don't need to open. Right. Okay, we'll show you next.
That one.
So we're championing it because as part of ALS activities, we want to encourage frequent review of patients so that you don't give it open it in. So once you rounds every day, so you need to close the prescription. But there's that conversation at certain places that the driver says, oh, well, we don't know how long it's going to resolve for. Let's say that our relatives are not there, so when they come, we want to buy everything once and supply. So we don't want to ride 24 hours and all this. My point is that close it for us. So it's documentation. If you want to do for 300 days, write 300 days. They can go and buy it. That's but when the auditors come in to do the PPS, for instance, it should be closed. So there's no duration on it. It's no. And I hope it's the way you are saying it's off because when you look at data across the PPS, Ghana, Africa, Europe, it's not as high as other things. People are making about 24% something, but I hope that you push the Ghana rate up on the
I think that one we can. I'm sure that one.
No, it's supposed to be, but you have to document that. Okay, I'm writing. I make a for
24 hours.
24 hours.
That one
IPs, that's why
Why
IPs is 24 hours.
I'm not.
It's not even.
I'm not
His
questioning
point
what
is
you
not
said.
in the length, but whether they state the number, the period, whether they state the duration. That one is.
It should be stated.
Once it is done, then that works. Then the number of missed doses. So when you go, you count the number of missed doses. Then there are reasons for the missed dose. This document tells you.
Is it the nurses?
Yes, chats. Yeah, so that's what you use the chats to do those things. Whether the patient couldn't catch it, whether they didn't accept it. There's a code for it. That's number 17. So the 17. Close.
Yes.
So 16, yeah, so the number of missed doses and the reason for the missed dose out of stock. They couldn't purchase, patient declined, other reasons, multiple unknown reasons. Because we will document it, unless it's no, it's minimum interaction. Yeah, for that one, yeah.
For the region, I want to cover.
So, we don't interact with
No, the one people, no.
the staff on the ward, or the nurses on the ward, like patients. We don't interact with them, we just put them in.
It's access. Like I said, if you don't minimize interaction, then we'll fix everything.
So we don't interact with ourselves, like amongst
The auditors.
So you are collecting the data.
You can't do without
Is the
interaction.
patient and the
For each
I'm asking
patient.
because sometimes you don't come across something and the doctor with the team will say, no, this one is because of this or because of that.
But I mentioned it in the beginning. That speaks to the integrity of the data collected.
So the team will communicate, but we don't try to clarify anything on it.
You see, if it's not done, if it's not there. If it's not done, it's not, like I said, it's your own data. And then you want to, if I try to improve, you want to be true to yourself and say, oh, this, we don't have this capacity. And then you can find the capacity. But if you say that, oh, we can do it, and then you cannot do it, and it costs more time. So that's why I said, in some person, nobody was not. If he's on the medical and pediatric, he doesn't do the pediatric. He doesn't do the medical, he does pediatric. He goes to assess, or then he tries to explain. He doesn't know what the explanation is. I go to where I don't know what is essential and then we want to fix it. It's bad. It's what?
So some of the issues have to be fixed.
You're not fixing the issue.
I remember there was a time we went to one of the wards, they prescribed suspension, and the prescription was 5 pills, just 5 pills, QI. So the 5 pills, depending on the milligram. So if you are the one said, how do you know exactly the milligram you are supposed to give the baby? So we have to call them to correct that. We call the doctor, give us a specific milligram that he wants. Because depending on what you have, that's where you can get your 5 pills. But
So
this is just 5 pills.
I see the beauty of that is that now people the beauty of that is that when a prescription test came, you shall not arrested by a pharmacy. Again, it speaks to quality of service. So you see, as the auditors, if we found a problem after recording, we can say, okay, we have to fix that, and we go out. But if we fix the problem and awaiting the audits, then it affects the data. So is it because you would have gone for rounds, AMS rounds and all those things. Those are problems that you should fix. The auditors for the PPS are going to collect data for PPS. They're not on AMS rounds. So like I said, you can put the data, it's poor documentation, affect it and say, oh my people, you missed this one, but I'm going. You can do the solution there, but then you don't record the solution after.
At that point, you were wondering what to write for the unit.
You'd have done a calculation with it, because if there was the medication there. 125 in 5 months becomes 125.
So I was supposed to assume that it's 125.
That's documentation there.
So I called the doctor. What milligram do you want to give the child? And
How was it displayed? How was it displayed?
Okay, so I think is this, are we focusing on the prescribing or on the dispensing, or is there a particular aspect?
Prescribing. No dispensing.
Is this prescribing? So if it's prescribing, then the dose should know the prescribing intent, not what was dispensed. So for assuming there were 2 different strengths of that, for example, if it was amoxicillin, we know this was different. If it was amoxicillin where there are 2 different strengths of the suspension, then 5 mils wouldn't mean anything.
Yeah. True.
Yeah. So in that case, at 5 mils, they wouldn't even know what to report as a dose for the 5 mil.
So that's why I also say that right now the prescription should have gone to pharmacy. So it was that discrepancy. We should have addressed as pharmacists over the difference.
Yes, but it wasn't addressed.
Yeah.
But now we are collecting the data. What do we write as a dose?
So what we have there? So what we have there?
What has been dispensed?
What has been dispensed? What you are going to use? That's the way around this one.
And if it hasn't been dispensed, they will write no.
There's no dose. It's a drop down. If you don't put it, you can't continue. If you don't put it, you can't continue.
So the no dose is an error.
So it's an error in the collection because there would have been a dose over there. Something the only way you can go about is to use what you have there. You can't continue, you can't save.
Okay, so we have to find
Strength in 5 minutes. Then write that one. So that will be 125 milligrams.
Meaning they have to make an intervention there before they
So
can.
that's not an intervention. That's not an intervention. Whatever was given them over there, 5 mils of that would have equaled some amount of weight.
Look at the provider was said. Look at the 5 minutes.
so at the time,
No, so
sure
if-
that what
okay.
they give the child is what we still have.
You see, so that it speaks. So that's what this does. So the PPS
It's an error that we have to correct it.
You see, there is no intervention from PPS.
Yeah, but is there this one, we are
Speaking
looking at
of data,
prescribing
after that,
practices and things like that, where a prescriber doesn't even state their dose. How is it calculated?
But there is no way the prescriber will not state the dose.
He didn't say this on the dose.
It's stated. It's stated the dose before you.
In volume.
Yes, that's what happens.
5 mil
It's for you.
in volume, 5 mil of what?
Of fructose.
Of which strength?
So you see, that's what I'm saying, that would have happened.
So that's not a dose.
The patient is on the medication. So if it's not a dose, how are they administering the medication at that point before PPS went there? The patient is on active antimicrobials.
On active.
Yeah, so the medication
So
is
you are not
being given.
basing it on the prescription, but you are basing it on what the patient is taking.
So the prescription predicates the administration. The patient they are going to meet is being given 5 mil of a medication.
So you look at
So,
the actual dose
of
of
the-
what the patient
That's
is
how,
taking, and not the prescription.
That's the prescription.
So can I continue to add that when I found out, the doctor said it's 2.5 milligrams that he was taking. 2.5 milligrams. That was 2.5.
You see, like I said, the PPS will not go and assess whether it's over or under. Whatever, so you see, that means that the patient was being given 5 mils before it went
That
down.
was what was recorded.
Was the patient being given 5 mils?
Yes, that was what was recorded.
Then that is
So it's an error.
Yes.
I understand that's an error. 5 meals of sweet strength.
You see, you are looking at
So there was certain way that very movement that was there. So I called it that we sorted it out. Yeah. So
what was the
on the form we wrote the milligram on the right one.
these are 2.5.
No, 62.
62.5.
I see. When you went there, they were given 1 to 5 milligrams. You have
There was no 1 to 5 stated.
no. You said they were given 5 milligrams. So when you went there, you're not supposed to make any interventions. So record what's there.
They don't have meals.
And I'm saying that so over there, you'd have converted to milligrams.
Using the product available.
Yeah, this is. That's all.
I'm happy it's coming up because, I mean, this is an unexpected error that shouldn't have happened. It should have been captured at pharmacy before it even came up. So aside it's picking prescribing issues, here we are picking dispensing issues too. So though the PPS might not generate a report on the issue, these are attached comments the team that conducted the survey can bring up to DTC and then other bodies for it to be addressed.
So I mean, but when you're doing your trainings and your dissemination, then you can mention as well. Those are isolated cases or that you can mention. So what we used to do is some care issues that were not recorded by the BPS, we write them on the application form. The form is yours, it doesn't go anywhere, it sits with you. So then when you're doing reporting for these things, you can, because when you're reporting on BPS, you'd also state the challenges, I mean, as part of reports in conducting the BPS, right? So then that's captured over there. Any, so we want to finish here. Okay, so was the treatment targeted or empirical? That's the next one. We see a lot of empirical, we have to target it. Now the appendix 4, that emphasizes relevance of the microbiologists or the lab experts on the team. That's when there's a long list of the microbes and then there's some codes and categories. So they would have increased that in the respective areas. So I'm worried because you're going to say 1 in 100 or 200 sometimes for this one. That's for the inpatient PPS. We'll skip the, because of time, we'll skip the platform entrance. We'll find a way to do that because I was hoping that, you see, I was going to do a whole PowerPoint presentation on it, but I felt if we did that and come and do this and become cumbersome, so we went straight to the MPS. So you appreciate it better when you join the team to do the data collection. It becomes easy if you join. So that's for the IPG. For the data entry, I'll liaise with the people doing this out. It will be easier. Pick a unit form, we'll use 5 minutes, run things in it, and then for the details, and I'll finish. OPD unit form. Let's do about 5 because it's similar, so we shouldn't have to spend a lot of time on it. Are we there? So the uniform is similar, the same categories you have. I mean, but that's the same. You have the general OPD, then you have some clinics. There's surgical and eye and all those ones. You see the respective codes to use for those ones. The same for, we won't see activity anyway, right? So the same that we use for those ones. Let me reflect so I can run. Are you all with me? Let me speak for you. So for the demographics, I mean, you can put that in. The day of the surgery, the surgical was yes or no, it was something let's compare. Then the number of doctors at the OB usually, so if it's room 1 you pick, how many doctors were in the room, how many next one, but then pharmacists also. You can use the pharmacist area because usually the OPD supports them, so that's okay. Then others which you may not have to use. Then the starting time. For this one, you're going to use more than 4 hours in a day. More than 4 hours in a day. And that 4 hours is not quality data. So more than 4 hours. So if you start at 8, you finish after 2 hours. You can start at 9, finish after 1. You want to do 6 hours, that's for you. But 4 hours should be enough to get like a proper data. Then we hope you can do this.
In the day surgery, can you show how much?
So the beauty about this one is what happened. So that one, okay, the variables is whether the surgical procedure is taking place in the unit during the surveillance or not. Right. The document will leave with you, so the things that I'll jump off, you can get them in the appendices. Right. So the patient form. This is the latest one actually. So every time when you're doing the thing, you don't print and be using it over the time. I advise that you download it as and when you want to do it. This was May 2020, so that's about 2 months ago. This the latest updates on this one. The latest on the IPD is about 2024. So every now and then they change something. So it was simpler, it's getting a little more complex, but it's getting better because it's beginning to identify more things than it was before. So the reason I had challenges about having to collect data from the pharmacy was you might miss certain things. So what we did was that we positioned one at a time. Just listen. You don't interact. So as a patient, the doctor is seeing the patient, you record the information you need. If you didn't hear something, you can ask, but minimal. But the downside to that also is that we realized is that the prescribers became holier than before. And it's very easy. If there's someone in the room, I mean, because one person actually said, hey, Kofubiaba, intimate antibiotics. That's a clear point that. You see, the beauty of these things is that, so what I'll do sometimes is, before we do the thing, I'll ask for their REM data, so you can see the antibiotic use. By the survey, it's by far lower. You can tell that the presence of someone in the room over there has changed, because they are conscious that there's someone over there, so someone who could be qualified enough to know that what is wrong or right. But my point is, it doesn't matter. If you thought you want to give, you give it. That's why I want the auditors to be as invisible as possible. Don't be noticed. I mean, they don't wear too colorful dresses or anything. I don't know how big the rooms are, but that's what happens. You know, so the one auditor sits inside the room with them and just listen. Because some data, so there. Say again. Oh, we're just trying as much as possible. I'm looking for. The forms are not. There should be a patient form. There are 2 patient forms for all people. You have them. Let me see the other one. Yeah, so there are 2 patient forms for all people. Just one. Your sorts out for you later. I'll sort out for you. So everything we did for the IPD, we're doing some for the OPD, right? But about the prevalence, there are some patients who will come that will not use antibiotics. We report those ones also. Yes. For that one, for the see, so there are 2 forms for this one. I'll find it for you. Oh, you have it already, so That's okay. So this one, this is for the patients on antibiotics. Right. You'll be you see, you cannot wait for the whoever is taking the data cannot wait for to realize that it will be antibiotics, so you start with this one. So start on the other one. The other one is simple. It's big and then it has a lot of how do I even describe it? Let me write it so that we see that. So like this one, the other one is like an A4 sheet, right? Then it's plenty. So when you look at the presenting complaints, you see that, so maybe if there's one patient and the complaints, maybe 1, 2, 3, 4, like that. Can you picture, right? So whatever the claims number or whatever was recorded in here, some demographics, and the rest will be the presenting complaints. What you can see there, temperature, sneezing, all those things will have been here. So you just tick them when necessary. I'm showing this form because when you start the collection, start on this form. Start on that form. When you start on that form, then you realize that the patient will have an then you here. That way you just come and transfer the things from here. They can continue. Because you would have been asking patient questions. Oh, how are you feeling? Tell me whatever you do, so I'm coughing, I have a fever, I have ABC, whatever. So you'll be taken and be going. So the moment you realize it's going to be antibiotic treatment, you have to this form for that patient. I'm saying because if you see 10 patients in the 4 hours, not everybody will come for. Some might even come for some clinic. For instance, they won't have any antibiotic treatment. So you keep recording so that when you hear antibiotics, you move here and you continue from there. Then later you can just take the corresponding whatever here and cross it out.
So can we have 2 forms for the client?
So you have 1 form for clients and antibiotics. You have 2 patient forms, and I'm saying that start on that one so that when you realize this antibiotic treatment, continue on this one. To continue here, I want to help you so I don't. You see, the doctor will not wait for you for anything to save the time. Fortunately, you see, when we started, we didn't bucket quickly, so we had to chase. So what happened was, so we made the pilots. When it came fresh, we did the pilots, then we saw the gaps. So I'm sharing with you the gaps so you can move faster than you would have done. Start on that form. Record the presenting complaints. When it comes to antibiotic decision, take this form for that patient. So if that's patient number 5, start over there. So you have the first one, no antibiotics, the left. The second one, no antibiotics. Maybe the third one has antibiotics. You are still the number 3. Just pick the data like it is. The presenting complaints, we're taking them over there. The moment there's antibiotics, come on this one. No, then you pick this one. Then you continue. But mind you, you are going to transfer over here, not in the room, because that time the doctor might be in a hurry. Next patient is coming, but don't wait for you. Right. Otherwise, next time, don't let you come and do the survey. Come and do them. So, then after you can cut it out. Because in the data entry, you enter this and that. That is how you measure prevalence. If you measure only this one, you tell us that anybody that came here has antibiotics, that's 100%. That's poor data. Right. So the same thing. So the only difference is the patient complaint. So you be hearing, did he say he has an acute cough or a chronic cough? Was there sore throat? Was there abdominal pain? Was there vomiting? They're all inside the thing. If it's not there, none or other, then it helps. You can try to write it, but the problem is also that there's a lot of drop-offs, drop-down options. So you might not be able to add your own options to it. Right.
Okay. I have a question. Taking the signs and symptoms. See one sample for the eye, it uses tearing. But for the glass, it's itching of the eye. So do you think the same thing? For example, close connector sample, then on the fibromyalgia or myalgia.
That's not a diagnosis.
No, complaints, yes.
Complaints,
Yeah, those complaints. The doctor frees the day of myalgia.
So it's captured as
So, okay, that's what I want to understand. So we just
pick the most appropriate. We already executed. The most appropriate already. Yeah. So this is a form I was talking about. So, right, this is the one I draw over there. You start on this one. If you start here, by the time you know this, if you start here, you cannot start here as a point because the patient might not have antibiotics, so you'd have wasted this form. So you start here. When you hear that's the antibiotics, and you just continue here. And you come and transfer the bio data and the resulting complaints over here. Yes, we can be able to. Because if you did everything here in the antibiotics, you can't call back the patient. It becomes, well, you have to go back to pharmacy to refer. That's extra work. So to make it easy, that's what you do, right? So the same process goes for the antibiotics. For the antibiotics. After presenting complaints, you do the age, the weight, and those ones, and sample taken. You see, the difference also here is that you might be there when a patient comes with labs. So some will have labs done, some won't have labs done. So if the doctor feels like they want to give antibiotics because they've confirmed without a need for labs, they will start the treatment. Right? You won't have a reason to start. There will be no biomarker. But someone might be coming for a review and you are there. Yeah, once you are there within the time slot, if it is 8 a.m., whatever time you have allocated, that happens. Right? Then learning mobilities, are they directing, are they whatever you indicate that for us? We have done the antibiotic treatment, so I won't take too much time over there. The only difference is that the dosage regimen is further explained for compliance. It will ask you for compliance in drug choice. It will ask you compliance for duration, compliance for frequency, compliance for you state all those ones over there. Right, so that helps. That's also whether it's the same, it's as simple as the same thing, yeah. Whether guidelines exist for the treatment or not, you state it. But very easy, we don't get lots of missing guidelines on this side. That's very documentation. So that's it for the OPD. I'll show you something in 2 minutes and then I was thinking of it. So I'll just when I said I was born before, you didn't believe me. My time was typewriter. Okay, so when you do the data upload, this is just an example for the OPD. This is a feedback deposit, similar to the IPD. It can be about 65 pages sometimes. So I'll just show you what it expresses. Then you understand that all this you are doing will be captured somehow. So I mean, all of us in the world are using it across. I mean, most of us. Then there's a lot of English, more English. So it captures this for prevalence I was talking about. So you can see that's your facility, that's the facility. Whatever your ID is. P1 is the first format. So number of patients that you did in the OPD about 207. The number of patients that were treated 34.3. That's your facility. I spoke about benchmarking. So that's the example. We can now we can compare you to the country. So if you were getting this for your prevalence, it means generally it's higher in the country. You can compare to the continent. Then the facility type across. So primary healthcare across the whole, you're able to benchmark it. You can see what their indicators are. Then in Europe. So you can see whether you're doing better than Europe or part of the prevalence data. So this is according to the indications, right? Whatever the ones you choose for the code. Another one. Speak about this. Once you go to the very key areas, more prevalence data. Even with the antibiotic types. So it has a consumption thing for you, stratifies it all for you. That's an example of the consumption. So the antibiotic, you can see how much you are consuming. Close this one, you'll see its relevance later in other slide. So the most used here are penicillins. Very easy because your treatment guidelines have lots of penicillins. They are more in the access group and all that. And then you can see, you can compare the consumption to other facilities here. More consumption. Okay, so then the classification of antibiotics. So you can see in the same consumption, you can see what you use more, the percentage, and also it's all inside there. You can compare even the class against each other. You can also use more. But very easily, most of us use the beta-lactams more, without cephalosporins or penicillins. Then, okay, so the indications is the what to also quantify for you and what to do across them. This is just another presentation of the antibiotics. Yes. Most frequently used antibiotics. Yes. Another important part is the word classification. I think we spoke about it in the access, reserve, and watch. The whole target was 60% globally. Consumption of access groups globally was 60%. In January, it will change to 70%. So right now, I'm supposed to consume an access group 70%. I'll say because I might not have the chance again to say, but the whole thing about AMS is that we don't decide for you what to prescribe as a committee. So we're not antibiotic police necessarily. I mean, we're just still what's up. So what I'm saying is that you don't try to beat the target, so it affects your prescription. Instead, I was saying if it comes at under a period of review, you saw 10 cases, and in those 10 cases, 8 of them have some infections. You use it will show your antibiotic use as 80%, but that is what's supposed to be there. So you don't overly focus, but we try as much as possible because that's the only way we can help reduce resistance. It was experienced that the access group, they are effective, and my groups are successful to them, but they have a lower risk of infections now. So we use a lot of them in access group. So we want to use those ones.
Lower risk of
resistance, yes. They have lower risk of resistance. So as the resistance risk goes higher, they are moved up to reserve or watch. Watch is last resort. The watch ones are where the TB ones are, the fluoroquinolones, that's where they are, and the watch. And all the ones that are new that we don't want to expose because we agreed yesterday that we don't have any antibiotics coming in new classes. So we want to safeguard the ones we have. And we also agree that our main driver is use, rational or irrational. So the point is, if we think that our amoxicillin can solve the problem, we have no business jumping to levofloxacin because amoxicillin would have. When you compare treatment guidelines across, so when we're developing ours that time, we sample. I got some from the UK, we got some from all across. Some of the antibiotics that we deem obsolete are working in those places. It speaks to the geography of the amount. I mean, how variable, how it varies across. That's why I find it laughable that someone will call a pharmacist and say, my pharmacist in the UK said I should use this for this infection. It's flawed because over there is, the sensitivity patterns are different. So you cannot say, better attacks are many things, but not some of these things. And the beautiful thing is, when you look at the data, like raw data, I can show you later, we are better in testing than them. Some time in some was in the UK, and then one round, so we're talking about when we say we've done this, they're surprised that I don't agree. The prescriber said they don't mind. He's a specialist. You can't tell him what he wants to do. It's the same thing we have here also. They might have access to their medications, but in use, it's not like they're better off served. I'm not talking them now, but I'm just saying that they're up there when it comes to providing that quality of service. So this for the aware classification. There's a watch, not required. Usually we get a lot of these two, but sometimes you get the unclassified or reserve. The bigger you are on watch and reserve, the poor control you have on AMS, and it's impact your AML. So that's what it looks like. So I was looking for another quality indicator. Okay, that's not here, but that's fine. That's for the IDP. You see where you see guideline compliance, reason and documentation, diagnosis document, you see all those things. Those are the indicators you speak to when you want to talk about some of these things. I did an audit, and then pharmacy, just because I was making a point about medication errors and all those things. And per department you see medical order, they were guideline compliance. And finally, everybody thought OBGYN were worse at those things. But per the data, OBGYN was the best amongst them. So those things happen sometimes where we assume that they are difficult in that department, but sometimes when you do some of these things, you get better results there. That's all. Thank you very much.
No, not the shortest presentation. Okay, while we wait for snacks, please can we have questions and answers or contributions or anything, even if it's outside EPS? Anything that you think can improve our asthma prevention? We don't want to go straight into the next. We want to stretch a little bit and have a snack. So let's ask the questions, we stretch a bit, by then snack will be here in the invitation. So no question. He confused you really well.
No, I think the discussions
Or
went
you
on whilst.
understood. There are two things. Either you understood very well or you were wrong. He confused you. You understood. Things are clearer now. Okay. Anyone who is very good at ice breaking can give us something. MC is not here, but who usually gives us the icebreaker? Is he the one who does it? You want icebreaker? You want to spread? Okay. We can just take a little bit. So when Western was sending their information, didn't you see that they gave like Western order price? So those ones can't be accounted for. They know the quantity, but except for the money. So how do they manage themselves? Where was the processes
And you see this one like this, the community, and the government, they have used
and then protocols. So these are the topics that we'll cover under this. Okay, so we'll talk about why hospitals are a critical component of the global antimicrobial resistance problem, and then the institutional interventions that drive the rational antimicrobial use, define treatment and clinical practice guidelines, and then the role that the guidelines play in microbial optimization. Talk about examples of the treatment guidelines that we have both nationally and then globally, and then we'll also talk about what makes guidelines fit for the purpose. So why are hospitals a critical component of this global issue? So you see that there's a high density of antimicrobial exposure per patient. In the hospital, well, that's where we have a lot of patients. You have patients coming in contact with other patients, have other patients coming in contact with staff. Okay, so that's where you have a high risk of resistant organism transmission via human beings, equipment, and then services. So we are talking about the environment also playing a role in this. So that's a gateway, a very good gateway for the relationship between the community and then the hospital, and then it enables spread of microorganisms or the microbes, and then there's a higher tendency for resistant strains to develop. So how does the hospital play this role as well? So it amplifies this in 3 different ways. So we say that there's selective pressure from prescribing. Often we see that we prescribe a lot of broad spectrum antibiotics, or we say that, oh, when a patient comes in, they're suspecting that they have one infection of the sort. We haven't been able to do the culture and sensitivity yet. So we want to now start with an empirical or broad spectrum antibiotics, so as to wait for the culture and sensitivity results. And then this fosters, okay, resistant strains to develop faster. Okay, and then also there's cross-transmission pathways, like I mentioned earlier, from one person to the other. It's not just staff, but then patients as well. And then you have the equipment also being a source of these microbes. And then you have high-risk populations. So patients who are in the ICU or patients who have various cancers and who are in the oncology unit. You have patients who are treated surgically for one reason or the other, and then you have the neonates who are also have very low immunity and then are susceptible to these microbes, and then it increases the issue that we have. So why is this a problem? Most of the time when we look at things, we are always looking at the burden, the national burden as well. It's been found out that as many as 1.2 million people because of bacterial resistance. So this problem, something that over much of the because see that we have as many as 1.7 million people annually. It's quite a significant issue that needs to be dealt with. And then it is projected that in the next 24 years, as many as 10 million people will die from this. We don't do anything about it. And then you see that 60% our national target share of elderly in total level adherence is one of the most cost-effective ways that to slow down this trajectory. So in institutions, we want to what? This antimicrobial risk. So we have 6 coordinated levers that we want to have in the institutions to safeguard the effectiveness of antimicrobials that we have. So we have the infection prevention control, we have the therapeutics committee as the same as the and then we have the institutional formularies, then we have the microbiology lab, and then antimicrobial stewardship, and also the trends of the practice. So all these 6 work together to bring out the required aim. They don't work individually, but they influence each other positively to be able to achieve their goal. So IPC, we talk about hand hygiene compliance. So most of the time when we do peer review and others go around and say that somebody should wear the glasses, and most of the time in practice you realize you say, oh, hand washing, and then when you just come out of the sports, then you realize that okay, so these are things that we need to take seriously, because sometimes we think that, oh, I've touched this. When the COVID came, you had sanitizers everywhere. Even go to the ATM, you see the sanitizer dispensers there, and you think that, oh, you press it and it's empty. I'm like, they should take them away from there. What are they still doing there? You see, like that, there's something there. Okay, so number 2 is what? Isolation precautions. So with people who have communicable diseases or communicable conditions, upper respiratory tract infections or chest infections are the commonest. So people who are unknown carriers or people who have been diagnosed with such conditions should be isolated, and isolation should be done properly. Sometimes you don't have areas to isolate these people, and you see someone who has come and has a cough and is not well isolated. So these are things that we need to really do properly, okay, and know how to do properly. So sometimes you know how to do a thing, but the way to accomplish it, the strategy to be able to achieve it is not really known. Okay, so also we need to, the third one is surveillance of healthcare associated infections. So it is important that we actively monitor these healthcare associated infections so that our IPC is top notch. And then we also have to do environmental cleaning. Cleaning of our environment is very infection of high touch areas. Okay. So what are some of the things that we do? I guess it's a very good at resources. Is anybody here from ICC? IPC. What are some of the things that we do to disinfect our high touch areas? And number 4, standardized disinfection of high touch areas. So what are some of these high touch areas, and what are a few of the things that we usually do?
Okay, so the high touch areas, the door knobs, the switch knobs, and mostly these are the two most categories. So during training, they are advised to clean this frequently, especially like here, everyone who walks through the door, use the door. So unfortunately, the sanitizers are the problem. As you rightly said, during COVID, we had maybe going forward, we might have to, during this time, so we have to bring alcohol up so that the spraying can type. But from time to time, we spray the door of them, use tissue paper to rub it off.
So how often is the recommended, the frequently, I think about frequently, how often during the hospitals most of the time you run 12 hours, 24 hours, so within that
per shift.
Per shift.
At least per shift.
You have to do that. So I remember quite well that when the COVID came and then in times where there's a lot of upper respiratory tract infection, when I'm opening the doors, I use my elbow to open the door because I don't know who has touched the door. And even sometimes when I go to, other public places, or maybe you go somewhere and they are taking the kids to go and use the washroom or something, use their elbow. So they've learned that they only say don't touch the doors. Or then maybe when you finish washing your hands, take some of the tissue and use it to open the door. Okay, so the DTC, or the Hospital Therapeutics Committee, so this is an institutional governance body that's responsible for rational, safe and cost-effective medicine use, and is the primary vehicle for the institutional AMS. Please, can you pass me my water? So what are they supposed to do? They're supposed to develop and update the facility antimicrobial formula, and this should be done regularly because, you see that I was talking earlier on with Edna, and she was talking about the fact that every facility should have their, and now what did you say? Is it the antibiogram? Because the microbes change from time to time, so regularly you should look at it and then update it. Okay, so we're also supposed to commission quarterly antimicrobial use surveillance reports. Okay, so you put them together, and then most of the time you're supposed to look at it and see what it says, and then report or give feedback. And then you're also supposed to review the antimicrobial related adverse drug reactions. So most of the time we have these antimicrobial related drug reactions, or we have the forms, but sometimes we get reports, other times we don't get reports, sometimes we get the forms, other times we don't get the forms. We get the forms filled and then we send it, but then we don't do follow-up. So then how do we follow up, or how do we know what to do if another drug reaction occurs? So also the DTC is supposed to approve empirical treatment protocols from the local antibiogram data. They're also supposed to oversee the facility AMS teams work plan, and then also their targets, and then coordinate prescriber training, and then also carry out CPDs on the AMS principles. Because I'm a prescriber, number 6 speaks to me a lot. I was telling Edna that as prescribers, we're talking about the aware, that we are not even aware of the aware. So it's very important that we have this training and then these CPDs to be able to know what we are supposed to do. Because sometimes you find out that for conditions that don't need antibiotics, especially when we have upper respiratory tract infections during that time of the year when there's a lot, you find a lot of people prescribing antibiotics, and we are the guilty ones, the healthcare workers. We even sometimes advise our friends, oh, and I remember about maybe as long as maybe 13, 14 years ago, I said, oh, let me get an upper respiratory tract infection. When I take amoxicillin, it makes the duration shorter. I was a corporate. But now over the years, I've learned and I've devised ways and means of combating upper respiratory tract infections. I think about 2 weeks ago, a friend of mine is also a medical doctor, called me and said that, oh, all her children have a cough and cold competition, so she's going to buy azithromycin. She's going to start it. She sent me a message. I immediately gave her a call. I said, no, don't do that. Do A, B, C, D, E instead. So the azithromycin was saved. Okay. If I go through it, we won't finish this one. So that will have to be for another day. Or see me in chambers at a fee. Okay, so the institutional formularies. Okay, this curated, aware, aligned list of approved medication that concentrates the prescribing on first choice and then lower resistance risk agents. Okay, so what are the things that we're supposed, what are the drugs that are first choice? Sometimes we end up using second line or even third line antimicrobials when we missed out on the first line ones, just because we don't have knowledge, or sometimes we feel that from experience, we use the first line ones, so we don't work, various reasons. Okay, so we have to have evidence-based selection. This is to say you're practicing on evidence-based medicine. Everything has to have clinical evidence of efficacy, so that when we have the documentation, we can refer and say, like the lawyers say, what according to Article 207, blah 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 blah. Then we are referring to, so anybody can go and refer to it and then know that you know what you are talking about. So the aware, you know what the aware stands for? I heard him talking and saying aware.
Yes.
They said they don't know. It means that just all. Okay. Everybody knows. Okay, so please, you're going to tell us.
So the first A is for the acts about it. The WA is for watch, and then the reserve.
Okay.
The reserve.
Yes, please carry on.
The access ones are the first line, less likely to develop, for microbe to develop resistance against them, and then mostly narrow spectrum. And then the watch ones are usually the second options or second line that we should not be using as much. The reserve ones are a matter of last resort.
All right. So those ones, the reserve agents are supposed to be what? Senior approved cases. So you need authorization to use those ones if it's indicated. Okay, so the therapeutic substitution and delisting. So that one, approved substitutions prevent default escalation during stockouts. There's a defined process to remove agents that are no longer effective or the cost is not justified. Okay, so what about the lab? What are they supposed to do? So culture and sensitivity testing. This tells us the exact organism that is causing the infection, and then we can choose the correct antimicrobial agents. And then we have the facility antibiograms that have a local resistance data. So every facility has their XYZ microbes that they know are typically found, and then we can have a guide as to what antimicrobials should be used for these microbes. And then also early outbreak detection. So we are supposed to flag emerging resistant organisms before it spreads, and then we can't do much about it. And then the turnaround time, there should be standards. Okay, so timely results to enable de-escalation from broad to targeted therapy. So sometimes you have that you've taken a sample for culture and sensitivity, and then usually you will prescribe and then say that go and take this antibiotic for 5 days. You are waiting for the culture and sensitivity, which would usually take a minimum of how many days? Are you from the lab? 3 days. So 3 days. So okay, so an example is UTI. Typically we prescribe what? Cipro. So that's empirical treatment of UTI, because you notice that in this facility, Cipro is what usually comes as they're sensitive. And then it comes out that maybe it's over the weekend, so patients are going to take Friday, Saturday, Sunday, then they come back on Monday. So they're almost finished with their 5-day course that you're giving them. And it so happens that the antibiotic that the organism is sensitive to is nitrofurantoin. So then the patient comes back and then you have to tell them that, oh, stop taking this one, then take nitrofurantoin instead. Sometimes you can't do much about the turnover time. Other times too, you can do. So I think for some of the labs, they do what depends on what it is. They give it what is it, a 24-hour initial report, right, to tell you what So the antimicrobial stewardship. So this is a program that ensures that every antimicrobial decision is the right drug, right dose, right route, and then the correct duration of time for the right patient. Okay, so right drug, right dose, right route, and right duration. If you are supposed to give, I have a patient, he's an elderly man in his 90s. He has an infection and he can swallow, but then we think that if we give him IVs, it will help him, IVs for about 48 hours, it will help him to be able to overcome the infection faster and then he can continue with the oral medication. But then we can't find IV access. So what do we do? Continue with the orals, or if it's an antibiotic that can be given IM, should we give that at his age? Will the IM be okay for him, or will the oral be okay for him? So once we have this, we'll be able to take the right decisions for this elderly patient. Okay. So for the AMS, we have what? Prospective audit and feedback. Okay, so the teams review the active prescriptions and then provide real-time, non-punitive feedback to the prescribers. So it's not that, see that Dr. K prescribes this antibiotic. Why did you prescribe this? Then you put the person center stage. Then you give it to him, blah, 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 blah. You did that probably because you didn't know that was supposed to be done. So that's what you said, but to give non-punitive feedback to prescribers. Or you say that this doctor or this prescriber is always prescribing this thing. Let's zero in on him and then do something negative to him. That's not what it's supposed to be. It's supposed to give feedback that is positive to help the person prescribe better. And then it's supposed to see to it that watch and reserve antimicrobials that need sign off should from a designated AMS lead or the BTC before dispensing. So it's important to know that which antimicrobials fall under these two categories, and then we do needful. And then we're also supposed to do what? Prescriber education. So train continuously to keep the clinical staff abreast with what the aware classification is, and also for them to know what the local resistance patterns are. We stand up. I think that some people are yawning, some people are dozing. We want to jump. Then what do you have for snacks? Pastries, a lot of carbohydrates. So now pardon?
Sorry, I said the brain is being deprived. All that.
Yes, so then all the blood is being shunted to the stomach to go and digest the carbohydrate meal that you just had. So we want to do a 1 minute stretch or dance. And somebody was supposed to do an ice cream, and she said she hasn't eaten. We'll call her very soon to come and do that. Anna, who is she looking at? Or she is the one who does it? Okay. All right. So the use of the treatment guidelines. So if you are feeling sleepy, feel free to get up and stretch. Do a dance. Play some music in your head and then dance. Otherwise, I'll dance for you. Okay. So what do you call it? The 6 systems that I talked about, IPC, BTC, the formulary, the lab, AMS, and then the guidelines. So as I mentioned earlier, they're supposed to work together. So it's one connected system, they are not working individually. Okay, so the lab data sharpens guidelines, the BTC enforces the formulary, AMS audits adherence to the guidelines, IPC reduces the burden guidelines must manage. Okay, so it's a cycle, everybody works together to bring the desired outcome. So what are these clinical practice guidelines? Okay, so these are systematically developed statements that assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. So, okay, so a simple English is that what? It recommends what should be done by whom, when, and how. Okay, so it just tells you, it's a guideline that tells you that what should you do, how should you do it, and then who should do it, etc. Okay, so translates the best available evidence into clear, actionable clinical recommendations. And then so the diagnosis, investigations, and treatment decisions are standardized across prescribers. So it's not that Dr. B says that, as for me, when I'm going to diagnose pneumonia, I'm going to ask for a chest x-ray. I'm going to do culture I'm going to do sputum for culture and sensitivity. I'll by all means need to do gene expert or AFB for what? Acid fast bacilli. It should be standardized. Not that when you move from one consulting to the other or from one facility to the other, people are doing different things. Now it's all sing one song. When your country goes to the World Cup, everybody should be singing the same words of the national anthem. Some people should not be quiet. Everybody should sing the same song, okay? So specify first, second, and alternative line antimicrobial choices by indication. So when you look in the standard treatment guidelines or the clinical practice guidelines, it should tell you what you should use first, what you should use second. Sometimes you find out that, oh, they are using second line instead of first line. They are using alternative lines when we have missed using the first line. So when we refer to this, and so these clinical guidelines, they are not just for show. They are supposed to have them. They are supposed to have it readily accessible. I think 2-3 weeks ago when we met the pharmacy, I think they are the DTC or so in a facility. They came to talk to us about the fact that they are looking for soft copies for us to have on PCs so that we can refer to them. Because when they bring the hard copies, what happens to them? They develop legs. They walk away. Yes. And somebody says that, oh, when they share the bag, so when we have the soft copy, then we can have them. And we have to make use of them. Okay, so with these clinical guidelines, we're supposed to be able to have access to it and then use it at every level of care, as from right from the CHIPS compounds to the teaching hospitals. So the guideline documents usually contains diagnostic criteria. So we have the signs and symptoms, and then the test defining the condition. And then we have first line therapy, what's the preferred agent, what's the dose, and then what's the route of administration, and how long you should give it to the patient. So when first line therapy fails or there's a contraindication, what are you supposed to do? Okay, so if also a special population, people with renal failure, liver failure, or pregnant women, lactating mothers, pediatrics, what are you supposed to give them? A patient who has asthma, a patient who has ulcer, what drugs are you supposed to give them? Sometimes you find out that some of our prescribers find out about these things, others don't. I don't know whether it's because they forget to do this or I don't know. So these are things that come up as we have these discussions with our prescribers. And then we're supposed to monitor. So what do we track during treatment? And then when do we reassess? And then when do you refer to a higher level of system is all indicated in these guidelines. So the guidelines help us to do everything right. Okay, guide selection of the correct agents for the confirmed suspected pathogen. Okay, using the AWARE classification, right dose and duration. Okay, and then also reduce variation. So we narrow the inappropriate prescriber to prescriber variation so that we lower overuse and then under treatment. Overuse can lead to what? Toxicity. Under treatment can also lead to what? Resistance. Okay, so then we also want to contain the resistance. So build in escalation, de-escalation logics, and then the what reserve situation so that we protect our last resource antimicrobials. Then it also helps us to move on from empirical guesswork to therapy, precision in our therapy. So the guidelines map out the clinical symptoms directly with the AWARE prepared agents, and then this helps to remove ambiguity. Okay, then it also standardizes the dosing regimen. So we prescribe based on weight, age, renal adjustments, liver failure adjustments. Okay, and then we also can refer to how long we should treat for. Because sometimes you don't know, should we treat for 7 days? Should we treat for 3 days? Sometimes you have it that for something like azithromycin, it depends. Are we doing 3 days? Are we doing 7 days? What are we supposed to do? If you don't know, let's refer to your clinical guidelines. It's all stated out there clearly. Because sometimes, excuse me, we have that the correct duration is not specified. So then you have that the patient is not treated properly, or then we treat them for too long. So for something like H. pylori related gastritis or for enteric fever, you find out that sometimes people are saying that, oh, let's do 7 days. What's the optimum? Some people say, oh, it's 10 days. Some people say it's 14 days. And what is it? Stated in the treatment guidelines. Okay, so a standard treatment, why do I keep saying standard treatment guidelines? That's because that's what we use here. The treatment guidelines will help us to reduce variation and then contain the resistance. I think I've talked about this already. So what are the different kinds of treatment guidelines that we have? We have the WHO AWARE antibiotic book. Okay, so there are agent level guidelines on indications and then dosing and then the rationale behind the AWARE. And then we have the WHO essential medicines list. We have our local one here as well. And then we have the STDs, that's the standard treatment guidelines. Okay, so the WHO antibiotic book is a pocket reference which provides agent-specific guidelines on what exactly to do with regards to dose, duration, and then the AWARE rationale for common infections. So it explicitly links each recommendation to the AWARE category. And it's not only a hard copy, it's available digitally. Since we carry our phones with us all the time, we can quickly refer to those, or if we don't have it, we can have it on our laptops or desktops or whatever it is that we use, tablets, so that we can easily replace those. So it complements the national STDs, but then it doesn't replace it. The WHO essential medicines is one that is updated every 2 years, and then that's what we refer to in Ghana to come up with EML. Okay, then the antibiotics on the list are tagged with their AWARE category. So as prescribers, we should all have these available so that we can read them from time to time. Okay, so it's also used as a benchmark for procurement and then the formulary alignment. Okay, so we have our Ghana STGs, which is supposed to be updated every 3 to 5 years. Are we doing that? That's why I added supposed to. So that if there's resistance, we are aware of it early. So it also forms our national AMR surveillance and then the local antiviral data. And the clinical algorithms or protocols also should follow this. if there's deviation from first line therapy, must be documented and then justified. Then the Ghana EMLs is also supposed to, is now in its 7th edition, and it aligns to the WHO model EML and their way classification, reviewed regularly to align to the WHO model, and ineffective or high-risk antimicrobials are removed on review. It forms the basis of facility level formulary decisions via the ATC. And then procurement and frameworks contracts are built around the PNL. So we see that these guidelines are not only just for prescribers and consulting, but it helps to procure the medication that we need in our pharmacies and that are in our facilities as well. So what is the sound treatment guideline supposed to have, or what are the features or the characteristics? It's supposed to develop an expert committee, so people who have sound evidence-based knowledge about it. Okay, so it should be evidence-based, should be cost-effective, not too expensive. Okay, and then it should be aligned to the WHO model, EML and AWARE. Then it should be updated regularly. And then it should also have management algorithm so that we can follow it easily. So what are the key takeaways? So guidelines are the bridge between evidence and the bedside. So hospitals are high-risk amplifiers of AMR and require active coordinated institutional governance. The IPC, BTC, formularies, lab, AMS, and then the treatment guidelines work together as one connected system and not in silos. So the treatment guidelines that we have convert the national policy and evidence to consistent day-to-day practical prescribing decisions. And then a credible guideline to develop evidence-based, cost-effective, aware-aligned, and regularly updated. This brings us to the end of our first presentation. Thank you. Okay. So should we have a 1 minute stand? Standing is very important to do. Who can you introduce me? Thank you. You are here. I had written that I'm a lifetime medicine physician. You didn't add that. So lifetime medicine, we have 6 pillars that we use to manage our patients, and exercise is one of them. So I'm very good on not sitting for long, because sitting is the what? New smoking. Have you heard about that? No. So for people who sit for more than 4 hours at a time, they are predisposed to getting the kinds of diseases that smokers have. Yes. Okay, so for every hour that you sit, you're supposed to get up for at least 2 minutes. So to make it even easier, sometimes you're supposed to 30 minutes, you get up for 1 minute, or you stretch your legs or you stretch your arms, something. So the longer you sit, the higher the probability that you will die early. It is evidence-based. So the longer you stand for, the better for you. The body was not made to sit for long hours. And we are supposed to even sit right, stand right, isn't it? There are lots of things. So I'll come another time in a different place to give you all the filler.
Yeah.
Okay. You stand for 4 hours. What if you stand for long? What if you stand for long? Too much of everything is bad. So if you stand, you also need to take breaks. So that's why I say stand a bit, sit a bit. But then they say that sit less, stand more, or walk more, move. No, it's rather sit less, move more. Yes, so sit less, move more. Okay, so have we had enough or Edna? Okay, so whilst we are can you
all right.
to the next set of slides? If there are any questions, please direct them to Doc, my boss. Are there any questions?
I have one one is not directly to you. I want to relate it to something we discussed yesterday. One of the I'm not sure that was, but I was developing the local antiviral ground, and that we need to have our systems standardized before we can use the data. So currently we have a microbiology lab, which is we are conducting some tests during virus samples, and we are detecting some organisms, culturing them, getting which antibiotics are sensitive, which ones are resistant. We have some data based on what we've done. Can't we, in the meantime, can't we analyze that data and use it to develop some form of guideline, whilst we await standardization and the other aspects that we mentioned yesterday?
So then, for, like I said, most facilities have surveillance data. Because it wasn't standard, it was not the best to inform decisions. And then, yesterday, Dr. Papo also, they were saying that on the labs are applying that standard data for you. So you can do that for you. I haven't seen the data, so you cannot see and tell the quality of the data. So until we don't do this, because there are going to be legal constraints about using those antiviral we have developed, and if it's not standard, you can have small problems going forward. I mean, small big problems. I mean, for the legal
So how much data? A year's data?
More than a lot more, but for for the one to analyze about 4 years worth of data.
We will link you up with your counterpart at the region. They will come and support you to give you they will come and validate the data. If it is good enough, then you can use it. But if it's not, then they will standardize it. The standardization doesn't need your lab accreditation. That's not it. For you to enter all that needs to be entered into GoNet, and then we will track it. There's nothing wrong with me starting to capture data now and then in a year's time, then we develop it.
So in the meantime, without that, we cannot base any decisions on the data that already exists.
You will need them to come and validate. If it's good enough, then they will support you to develop the antiviral. If they think there are gaps in there, then we will start getting the right data. Don't be worried, there are so many facilities who lost their data because of the games. They've even lost the data. You are lucky. How are you storing it? How do you do?
Hard copy and hard copy. So that means.
Okay. So a lot of facilities are starting from they are now getting the data. So hopefully in a year's time then we will get
So a short pencil is better than a long memory. Otherwise, you would have lost your data. Use your short pencil to keep hard copy. Okay, please, let's continue. Okay, so institutionalization of the therapeutic committee and then the AMS program. Okay, so the AMS goes to be self-unit under the ETC. Okay, build sustainable antimicrobial stewardship structures within the GAP AMR 2026 to 2036. So we'll cover these. So what is stewardship? The foundational concept across One Health. What AMS is, define antimicrobial stewardship in the hospital. And then the strategic objective 4 of the GAP AMR as access, use, and then disposal of the components of the AMS is, and then composition of the AMS team. Talk about their roles, skills, and then the governance links. But in everyday parlance, what does stewardship mean? Can anybody just tell us what stewardship means? You want to give it a try? What is stewardship? You're a steward. To be a good steward.
An overseer.
An overseer. Or a manager. Okay. Any other English word? Synonyms and words? Antonyms. Or it's not coming. When you remember, you can tell us. Okay, so yes. So stewardship is the careful and responsible management of a shared resource, ensuring it remains effective and available for current and future generations rather than being depleted by short-term unchecked use. So we don't want to be like that steward that was given one talent, buried it in the ground, and then it did not multiply. So we want to be like the first and the second, so that we will reap more and then more will be given unto us. Okay, so antimicrobials are not an infinite resource. We agree to that. Okay, so it's finite. It's a shared global resource, and overuse anywhere erodes effectiveness everywhere. So you can't have people overusing it in one area and then there's a lack or there's a shortage in another area or another dispensation. So stewardship reframes prescribing from an individual clinical act to a collective responsibility, and it cuts across human, animal health, agriculture, as well as the environment, and that's what we call the One Health concept. So why is it something that we should address urgently? Okay, so in 2021 alone, there were about 1.14 million deaths because of bacterial AMR, and then by 2050, if nothing is done about this AMR, the projected deaths will be 39 million. And I calculated that 2026 now, so we have about how many more years to 2050? 24 years. So we are looking about a 1.6 million annual deaths if we don't check this. Okay, so it also should be that we have to conserve our finances. Okay, so there are a lot of losses when there's stewardship is not right. So there's about 1 trillion US dollars potential global welfare loss from livestock antimicrobial resistance in the next 24 years. So coordinated stewardship alongside infection prevention, vaccination, and safe disposal will be able to avert about 110 million deaths and then yield nearly 1 trillion in economic gains between 2025 and 2050. Okay, and we hope that that 1 trillion will not be used in wars against one another. How much has the US spent on the? Yeah, I heard it was about 37 or 39 million USD. Is it money that they have or they went to borrow it? Or it's oil money or gold money? Okay, so stewardship spans across every sector. Okay, so it's a shared responsibility. So from human health, okay, so in the hospital, primary care prescribing, and then the treatment guidelines that we talked about, and then animals and then agri-food systems is used in the veterinary area, husbandry practices, and then also biosecurity farms, and then also the environment. Okay, so wastewater, and then pollution prevention across the antimicrobial life cycle. And you see that, I mean, these days there's a lot of antimicrobials used in the agri and animal sector. The other time I was watching something on the TV and they talked about a man and his wife, and the man was developing hives hives on his, pardon? He was allergic. So he was allergic to his wife because he had developed an allergy. So then the doctor who was there, he was like, how can you be allergic to your wife? You know your wife all this while. And then the husband was complaining that these days she says that she's doing all those things. All she eats is chicken. She's eating a lot of chicken because she wants to lose weight to look, young and fit. So, for the husband, so that he doesn't go and, So then the doctor was like, So then he went somewhere and then they were talking about the farm and they were talking about the recycling use in the chicken. So then he connected the dots and said, so the man is allergic to the tetracycline because another doctor had told him that when he did the allergy test, it was tetracycline that it was found. But then, who uses tetracycline these days? So then they connected it and linked it to the chicken. But this discovery didn't save the marriage. They still ended up divorcing because they said it's not the chicken, they have other issues. So AMS is a coherent set of actions that promote the responsible use of antimicrobials to preserve their effectiveness. So it's not about restricting access to the patients who require treatment, but it's ensuring that the right drug is chosen, the right dose is given, the right duration, okay, and then the right route of administration for the right patient is done, okay. So, yeah. So, what the AMS program sets out to do is to be able to improve the clinical outcomes, to optimize cure rates, and then also to reduce treatment failure by doing a correct match between the therapy and then the patient and pathogen, minimize resistance, okay, reduce unnecessary antimicrobial exposure to the slow emergence of resistance strains and also to prevent them from spreading, and then reducing drug expenditure, reduce adverse drug effects, and then also the downstream cost of treating resistant infections. So, from principle to program, the stewardship is the principle, and then the antimicrobial stewardship is the program. Okay, so we have under the stewardship, it is a global cross-sectoral ethic which applies to any shared finite resource, guides the national policy, and then the GAP AMR, and then there's no single owner or accountable team. So when you move over to the program aspect, it is a structured program that is at the facility level, and it is owned by a team, which is the AMS team as well as the DTC, and then it operationalizes the stewardship. Okay, so it practicalizes it by audit, policy, as well as education, and then it reports measurable indicators to the hospital leadership so that you are able to take decisions for better outcomes. So on a day-to-day basis, how does the AMS program work? So there's real-time review of the active prescriptions. Like I mentioned in the other presentation, there's non-punitive feedback. Okay, so for the drugs that need prior authorization, we have the drugs that are under the watch and then reserve agents. So the medication that needs signing off, you have to be aware of it and then make sure that the right thing is done before those drugs, if they need to be dispensed, are dispensed. And then it also has the guideline-based prescribing. So empirical therapy is anchored to local anti-diagrams and then the STGs, and then continuous training on our web classification and resistant trends for the prescribers is also done by this ANS. So the objective 4 of the GAP AMR 2026 to 2036 is all about ensuring that there's equitable access, appropriate use, and then safe disposal of antimicrobials, diagnostics, and other health products across the various sectors. Okay, so the GAP Objective 4, WHO 2015, urges that all the member states institutes the AMS program, all health facilities, making institutionalization. I wasn't so big. It's a global policy mandate and not a discretionary initiative. So that is why we are here, moving from one facility to the other to ensure this. Okay, so what is equitable access? So the national AMR plans are supposed to promote equitable, affordable, and sustainable access to quality assured antimicrobials, diagnostics, and vaccines through cross-sector systems strengthening. So reinforces that supply chain forecasting and resilience measures towards universal health coverage. Then there's formulary optimization, market intelligence, and then strategic sourcing. There's food procurement and expanded manufacturing capacity. And then there's particular attention to smallholder farms and then conflict affected settings. So equitable access and then appropriate use. Okay, so access should be equitable and is expected to be paired with effective stewardship to promote appropriate use, to guide the local resistance data, and then using the AMS principles, and then the aware classification, and then the antibiotic groups. Okay, so also safe disposal. Okay, so unused antimicrobials should be disposed of safely. So through stronger waste prevention measures, take-back schemes, and public awareness, and expected to be built into the national regulatory and stewardship framework. So take-back schemes for the unused antimicrobials, both in the human and in the veterinary sector, and then extend the producer responsibility regulations addressing disposal of unused stock, and then integrate the disposal into healthcare facility and household waste system, and then reduce environmental pathways for resistance and safeguard the ecosystem. Okay, so diagnostics and relation underpin the SO4. Okay, so what are we talking about here? That under diagnostics stewardship, we want to expand access to quality diagnostics to enable appropriate prescribing, early detection of the strains that are resistant, to prevent outbreaks or to have an early response to outbreaks. We also want to regulatory strengthening. So the national framework must cover the full antimicrobial life cycle, development, manufacturing, distribution, use, and then disposal as well, and then curtail substandard products. Over-the-counter and unregulated online sales and substandard or falsified products must be actively curtailed. When I was coming, the driver that I came with was telling me about the fact that he used to work with one of these foreign pharmaceutical companies, and he said that he was working with them for a number of years and quit. So I asked him, why did you quit your job? He said he wanted to be on his own because he knows he has enough information to be able to say that what is being done there, the people have what you call it, an outlet here, or they have a manufacturing company here, he knows that they are not doing the right thing. So he had to quit his job because it was like his boss was now saying that you have some information that can destroy my business. So he had to quickly move out of that sector and then go and do something else. So he was telling me about the fact that a lot of things are going on, and I'm talking about this because of the last point. It's just a second, and let me just, I don't know, someone just keeps calling me. Let me just EMS components. So leadership, accountability, drug expertise, action and interventions, tracking and reporting, and then education. So when it comes to leadership commitments, which people constitutes the leadership? So the hospital executives and clinical leadership dedicate the financial, human, and IT resources that the AMS program needs to function. Okay, so this different category of people need to work hand in hand to make all this work. Okay, so there should be a formal recognition of the AMS within the hospital governance structure. So the AMS is there. It's not that, sorry, hello. Sorry. Sit down, okay. So they're supposed to also protect the allocated AMS team. Protected time allocated for the AMS team members' stewardship duties. So they're supposed to assign the duties of the members of the AMS team so that everybody knows what they are supposed to do. We're supposed to give them a budget that they're supposed to work with, the activities that they are supposed to do, trainings that need to go on for better running of the AMS. And then also they're supposed to have a performance review at the senior management and then at the DTC level. Okay, so there's also supposed to be accountability. Whenever we are working, we need to be accountable to someone or accountable to a group of people. So there should be one person who should lead, or there should be people who should be in the leadership. We work hand in hand, okay, so that the program outcomes are successful, and then they generate their reports and then give their reports to the DTC. Because the AMS is supposed to be under the DTC, right? Okay, so there should be clear terms of reference shared across the AMS team and then the DTC. Okay, and then there should be regular reporting of the indicators to the hospital leadership and define consequences and escalation pathway for near non-adherence. Okay, so there should be clearly defined ways of doing everything, or how they are their operation, the day-to-day operations work. Okay, so drug expertise. So there should be dedicated pharmacotherapy expertise. So there should be an AMS trained pharmacist, okay, who's specializing in that area and is able to anchor the decisions that are related to pharmacology as well as resistance. You should have working knowledge of the local antidiagrams and then also the aware classification. You should have the capacity to review dosing, renal adjustment, and then drug interactions. And then should also be the bridge between prescribing practice with formulary and then the procurement decisions. So you should be able to tell that these are the, what do you call it, antibiotics that we need to cater for the microbes that we are working with in the facility. Okay, so action or interventions, there should be audits and feedback. So review of active prescriptions should go on, and I think this is about the third time that we are seeing this. So the AMS, that is one of the very important goals that they should play. Also with the prior authorization, we've seen that and speaking about that. And there should also be facility-specific protocols. Okay, so there should be a therapy, the empirical therapy guide of local data to be able to guide prescribers as to what antimicrobials they should use for that facility. And then there should also be timely de-escalation of the route and then the spectrum. So IV to oral switch programs. Sometimes we put patients on IV medication. How long are they supposed to be on the IVs? When should we switch to oral medication? sometimes we say that, oh, the IV medication will work faster. Or Rebecca said, as for me, I want IV only, I can't swallow the medication. You know, it's not practical. He's been given some medication, he say, I can't take it. Mommy drip. Woman drip that net, there's a woman is broke. Or it's a woman is broke. Say, you're giving me this thing, I can't take it. But then, what are the guidelines? See, so we have to have say patients what? The expectations are high. Say, I'm fast. So I've come with my condition. I expect that you cure me quickly. So I've got time. Now, what my baby will be, so I'm giving you oral medication. Now, so I'm more mechanic. Now, I'm more mechanic. See, they call hospital no. It's all psychology. Okay. So what's another function? It's supposed to do tracking and reporting. So it's supposed to find process and outcome metrics to be measured routinely and then give feedback to prescribers and then leadership so that improvements can be attained. So the antimicrobial consumption is tracked and classified by the AWARE category. The facility antibiogram is updated and reviewed at least annually. Quarterly antimicrobial use reports are submitted to the DTC. The national data routinely reported to Glasgow cross-country comparison. Okay, so this is a very important aspect for what the antimicrobial stewardship should do. Okay, so education. So all staff who need to know about it should be educated. Okay, so this has things a cultural and professional shift on stewardship, which should be done over a period of time. So all new prescribing and dispensing staff needs to be oriented, they need to be trained. Sometimes our orientation is not up to scratch. When people come, they're just thrown into the system. Say what? Do they mean? We learn on the job. But then if you give them the guidelines, you teach them what to do from the beginning, then they will avoid a lot of problems along the way. So that if somebody comes and then gets a prescription and the medication is in the reserve group and you oriented them, then they know that they're supposed to seek authorization and then not dispense. Because then if you dispense, then you have what are those things that you call near misses and all these problems. Okay. So, and I think for sometimes the pharmacy staff in some of the hospitals, they get a lot of, what do you call them? No, not the reps, the people in the pharmacy who come, they kind of do their national service or they have interns. They come, so the interns come and then the turnover is very high. So as you get new staff, you're supposed to, orient them regularly. Okay, so CPDs linked to STD and AWARE updates. So the CPD is not the one that is being done online. Then you log in, your phone is somewhere, and then you're doing something, and then you get your CPD points. And you have to listen in and get the information so that you can use it properly. And then case-based feedback sessions reinforce appropriate prescribing. So sometimes, we've been getting a lot of feedback about treating the H. pylori related gastritis in our units. Every time they come and tell us that, I suppose, why are you prescribing so much of the triple therapy? Are you really getting so many positives? And then sometimes when you go in, you look and then you see that people are combining different medications, and when they go, they are prescribed. So it's like people are giving amoxicillin together with metronidazole, or they are giving clarithromycin with metronidazole combined in combination with the PPI and things, because they are not referring to the guidelines. So if you go for a training or you go for a CPD and you listen carefully, then you'll be able to do this. Or then if you notice that, okay, Dr. Thompson is not prescribing properly, and then you kind of say that, Dr. Thompson, you went to school for so many years, you are attending CPDs, blah, 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 blah. And then you don't, single out the person. You teach everybody so that everybody is corrected. And then if somebody has to bow their head in shame, they do it internally, Okay, that is not to shame anybody. We learn every day. A few days ago, my sister told me that she's been getting neck pain, but she has to sit down a lot to do her work. So she said she watched a video and there was a Chinese doctor who said that rounding of the shoulders contributes to neck stiffness and the resulting in pain. But she said that she's been to hospitals here and they haven't told her that. So she realized that when she straightens her shoulders, it eases the tension and then she has less pain. She was like, how come in Ghana she's never been told this? And I was like, oh, we are learning everything. So learning is continuous because what somebody has found outside there doesn't mean that all Chinese people know that this is what it is. So when we hear about something, we share the knowledge and then we get better outcomes. So the competency-based AMR content should be integrated into the in-service training. So which people are part of the AMS team? So we have the physicians, the pharmacists, the clinical microbiologist, infection control nurse, data surveillance officer, hospital administrator, and then the BTCN. So we have all these here. Okay. So 3 roles every AMS program is the physician or the infectious disease champion. That's the person who should provide the clinical leadership and then chairs case discussions, hold science prioritization decisions for the watch reserve agents, and then the AMS trained pharmacist is the one who conducts the audits and then gives feedback, reviews dosing, and then brings the stewardship decisions to the formula procurement. The microbiologist is supposed to be the one who comes up with an antibiogram, then is able to identify resistant or emerging resistance and then flags them before an outbreak occurs, and then also supports with rapid de-escalation from the culture results. And then we have the infection control nurse who links AMS with the IPC surveillance data and then also supports outbreak response and then isolation decisions. And then the data of surveillance officer maintains the consumption and the anti-guideline dashboards, which drive the audit and feedback cycles. And then we have the BTC and hospital admin that the AMS reports to. Okay, and then this is our last slide. Institutionalizing AMS means building a permanent structure. So because stewardship is a global principle, AMS is the arm, that helps to express it or that helps to operationalize the stewardship at the facility level. The GAP AMR strategy objective 4 is anchors AMS in what? Equitable access, appropriate use, and then safe disposal. And then a sustainable AMS program requires all the 6 complements, not policy documents alone. So a multidisciplinary team reporting to the BTC is what makes the program permanent. So thank you very much once again for your attention. She remains standing. How long have I been standing for? I think I need to stand here at 12:50. And it's 2 07 now. So I've done 1 hour. Should I continue now? So that I don't die early. Are there any questions or contributions? Yes.
Please, are you going to give us the slides?
Read the book. So give us the slides, We don't read the slides. What's it? Ah, so chupo pass. Forget never if you all.
Is there any other questions?
Any questions?
Any question?
Oh, if somebody makes a presentation and then asks a question, it means two things.
My issue is that it looks like all throughout, if you're mentioning IPC, and IPC comes with finance. And I get but even the stewardship, the budget, measure is there. The stewardship, AMS stewardship that we were doing. There was no budget done because we not sometimes I don't know, it's hand go hand come. We need energy doing these things. And IPC comes with a lot of other demands. It's not only with the hand hygiene, there are a lot of things when it comes to environmental hygiene, the things that we are going to need. Sometimes there are shortages, and you do your budget and there's no money and that kind of stuff. It restricts your movements. And talking about this, I think administrator is on here. You might be fair, but sometimes on the ground, you go and the monies are not there. For snack crowd to go, you go and sit there the whole day and stuff. And so I am
using snack.
Oh, I mean like the PP, I don't have anything. The PPS, the last time we spent the whole day, we have to go and attack Dr. Sek with his own money to give us lunch. And it's a whole day. And sometimes all these things come with it. What are so it's all boils down, and the logistics for these things, the hand hygiene, we need to plan. The stations are there. Public time, we had a station, working station are there in front of the security. Anyone that enters comes to wash their hand, and now it's no more there. How do we reach to these things? So it all boils down to the money and they will come with money. So I don't know whether Let's is here. Maybe let's so maybe sometimes when the pressure is coming from the top, and you insist that they do, it's hasty things more than then you come and sit down. We don't say it's yes, pipeline. The pipeline that never gets back. That is my issue. Because
she should tell us.
The resources, the finances.
I'm saying resources to do everything that has been discussed here has not been part of any of the presentations.
Of the ratio, what became leadership, and that explains why the DTC has all members of management. The one, the DTC is chaired by the medical director, the medical or a respected physician in the facility. It wasn't in vain that the WHO recommended it should be chaired by the care coordinators. It has administrator, finance, head of nursing, all members of management are supposed to be on the committee. So if it's not working, why do it? Exactly. You get me? So it is anticipated that we plan for, at the beginning of the year, all health institutions are supposed to make plans and budget for running the facility. So we are supposed to incorporate all those things into our planning activity for the facility. Incorporate it. And demand. You see, I mean, enforce it. At the beginning, no, don't say that. They are not, you see, management is there. Right? You see, leadership, Metro is here. Head of Congress is here. Metro is here. So that is it. That is why they are here. And you see, I think we realize all the things that are that is the core of the service delivery that we are doing. Actually, we are delivering a facility. See? And for me, where I stand, for me, it's one of the most important committees in the hospital because it ensures optimal health outcomes. That is the essence of the service we are running. So if you don't have money to run some of these things, don't have to talk about. So we should insist on it. And that's why we came now. Because the DD said that if you look at the letter he wrote to the facility, see that it remains a very important committee. However, it is hopefully underfunded, membership is not properly constituted, all those things. That's the reason why he's so particular. And until we strengthen our DTCs, patient outcome will not improve.
Please, your
all right. So as for funding, you see, we know that we are in an environment where funds are difficult to come by. Energy reduction, a lot of things wrong. And just to let us know what the institution is about and prioritize those things. Now at headquarters, they're talking about reprioritization. And rewash. So let us reprioritize things like these. You see, I'm happy accountant is here. Administrator is also gone. There is a committee in the hospital called the Entity General Committee, which oversees all procurement activities. Where I was working with Northern Red. Then, every time we go for Entity General Committee meeting, the very time we finish, we are giving notes our ideas. Okay? So we're giving. I think in hospital, that doesn't put in the
especially for the discipline.
That's it.
Discipline members.
You get me? So my question is, if we are able to make available funds to motivate those who attended our committee meetings, why can't we also make available to motivate partner DTC, KMS, APC? I can't do that. It's about prioritization. We can. So let us insist on it. Let us enforce it. And that is why DTCs and AMS and IPC are not effective in our health care institution. Who cannot take over the administration? They should be motivated.
The motivation should be substantial.
You see, having said that, there's an element. There is also an element that should mention. You see, motivation is not only expensive. It should also be what? Okay. So let us emphasize on the two. Not only external motivation, but also
I also want to add that, sometimes when these things come about, so we are doing UTC, we are doing AMS, we are doing all sorting up all sorts of committees, quality assurance, this and that. Sometimes we see it as an extra work, but it's all part of our work. And it's not all the time that we have to think about the fact that, we're not motivated, we're not being motivated. It's part of our work. So if we see it as part of our work, we will give it our all, so that when the motivation comes financial motivation comes, then the equation is complete. And if you are looking at the fact that, oh, the financial aspect has to come before we give off our best, then we don't do what is right. Because in other areas, in other jurisdictions, in other countries, you see that they are driven by the need to accomplish the right thing. That is what motivates them. So that when the other motivation comes, it comes as an add on. So let us own these things. Because sometimes even when we get programs or projects being brought on by our partners, so they brought us extra work to do. So then the people are like, you went for the training, you do the work. And you went for the money. Ask them there, when you go for these trainings and things, I see that nobody is giving this amount. So let's own it and then do what we need to do. Otherwise, we're just marking time that we will never move forward.
Thank you, Dr. So every round of applause. Last one presentation. We'll end the session. The last one. Okay, doctor. Okay. The last presentation before. No, not yours. Dr. Fam Ekewo. Take us through the last one. Let's welcome her.
Ensuring access to appropriate antimicrobials and other health products. So we will look at 5 access matters. We will look at the global and Ghanaian case for action. We look at the access framework, the dual imperative, quality and supply risks, the 5 pillars for scaling access, diagnostics, vaccines, and services. So we talk about access as a universal health coverage target. WHO has been tracking countries against universal health coverage. So Ghana, like this, we are being tracked by WHO to know whether by the year 2030 we will be able to achieve this universal health coverage targets we've been talking about. So the SDG target 3.8 commits most countries to this universal health coverage. And some of the key indicators that WHO is looking at to track is access to safe, effective, quality, and affordable essential medicines. So if we have access to safe, quality, and affordable essential medicines, WHO is tracking the country on that, whether by the year 2030 we will be able to achieve that target. So we're also being tracked on the foundation of care, especially the public health interventions, whether we are putting in interventions to protect the well-being of our citizens in the country. So we look at the scale of the problem.
access to medicines is a major global concern. Why is it a major global concern when it comes to access? WHO is saying that 1/3 of the world's population lack access to essential medicines. And 50% of us, we the local and middle income countries, 50% of us don't have access to essential medicines. And our procurement systems, the processes we go through before we procure these essential medicines, sometimes prevent us from having access to essential medicines. And sometimes at the end of the day, we end up buying these essential medicines twice the prices on the global markets. It's all due to the processes we go through when we are procuring these medicines. And 15 to 25% of what we procure also end up getting expired. We delay in procuring. And when we end up procuring to 15 to 25% of them get expired. We've been talking about financing. Finances we don't have, but we delay in procuring, and at the end of the day, after we procure, 15 to 25% of them get expired. So, why is this urgent when we talk about access of essential medicines to Ghana? There was a survey, point prevalence survey in Ghana in about 7 facilities. And this indicated that about 54.9% of our patients are put on antibiotics. And 70%, more than 70% of these antibiotics are resistant to the common microbes that are isolated in the facility, especially the E. coli and then the Klebsiella species. About 1.14 million deaths are directly also linked to antimicrobial resistance in our setting, that's we the middle income countries. So therefore, we have to make sure that access to essential medicines are taken seriously. So we look at the access framework. Medicines must be appropriate, available, and affordable. Once we procure these medications for our facilities, are we looking at the appropriateness of the medications? Are we looking at affordability? And are we also looking at the availability at the point of care? Sometimes the product might be available at the facility, but you go to the pharmacy and there will be nobody there to serve you. This doesn't make it available at the point of care. Sometimes the product is available and you go to the main stores, the syringe and needle, the cotton wool, they are not there. The store manager is closed and gone. You need the product to work with. The person says, I've closed. What can you do? That makes it inaccessible for your work. Now we look at the dual imperative to access. When we have access, that's enough stock, what do we do about it? At the end of the day, we end up misusing them. Especially when we know that, oh, cotton wool like also far. Oh, well, yeah, we ain't using it anyhow.
what happens to when we don't also have enough access, especially when it comes to the medications, the antimicrobial agents? So with insufficient access, we end up having untreated infections because the products were not available. The patient was not given the right medication and therefore the infection was not treated. Patient also tends to substandard or counterfeit drugs because the prescription was given to this client and they walked to the pharmacy and they didn't get the product. They will send the prescriptions out and walk into any pharmacy or any over-the-counter medicine sellers and they will be giving any form of medication at all which we can't substantiate the quality. So therefore, there's the need to make available in our facilities the essential medicines. Self-medication, when we have too much access to the products, we end up self-medicating. Oh, antibiotics, no. Oh, say when you're infected, how many there's no need going to the hospital to waste time before you get prescription. Let's just go and get it and use. So the dual imperative, when we have too much access and when we have limited access, we have to look at that. We talk about the 3 pillars of Objective 4 of the Global Antimicrobial Action Plan. Yesterday we spoke about these objectives. Who remembers any of the objectives? We spoke about research and innovation. We spoke about IPC and vaccination coverage. We spoke about awareness and behavioral change. If you remember those objectives. So the Objective 4 spoke about equitable access and appropriate use of essential medicines. So when we talk about equitable access, as DTC team, are we looking at having variety of these products available in our facilities so that and making sure most of them are on our NHIS list? So when the patients walk in and some of them can't afford the branded product, at least once they have the NHIS card, they won't be denied access to essential medicines. When we talk about the appropriateness of the essential medicines, are we looking at prescribing these essential medicines guided by diagnostics, maybe looking at the antimicrobials, looking at having access to the labs and making sure we have the antibiograms and then the tests, antimicrobial tests before we prescribe? Are we looking at making vaccines available? The DTC team, are we also looking at partnering with the public health divisions to make sure that vaccines are also available? I know vaccines are not managed by the pharmacy, so probably the DTC team, you don't include the public health units. Are we looking at including them and making sure that we also control and monitor the way the vaccines too are being handled in our facilities? Let's look at safe disposal as well. As a DTC team, are we looking at how safe we are disposing of our expired medicines? Why do we even have to sit down for our product to get expired in the first place? Because we know that when disposing of medicines,
we spend a lot of money to dispose them of. So going forward, we should look at making sure we strengthen the supply chain system so we don't end up having expiries to go dispose them off. Are we looking at even the vaccines, the vials, the empty vials? How are we disposing of them? Are we leaving some to be, washed away in our drains? Or are we making sure they are well incinerated at the end of our vaccination campaigns? Let's look at the drivers of poor access. What drives poor access? The first driver is poor selection. How are we selecting the essential medicines on our treatment guidelines, the formularies of the facilities? How are we selecting the medications on them? Are they backed by current evidence and local resistance data in the facility? Or we just think of just selecting anything on our formularies? Oh, this facility there, we know malaria is the what tops, so let's include a lot of anti-malaria, or is backed by data. The second driver we are looking at here is reliable supply chain system. How well are we looking at our supply chain personnel? As a DTC team, have we ever thought about empowering them, educating them on some of the results, on some of the things we discuss at our DTC meetings? How well are we including the supply chain professionals? If we are able to build their capacity, I know they will do a good job. They won't just go in and bring in stocks that we might not need and they will get expired at the end of the day. Are we empowering them on their key deliverables? Do they know about the reorder levels? Do they know the maximum stock quantities of this facility, the minimum stocks, the lead time before when they order, the time the stocks gets to the facility? Do they know about it so we don't end up running out of stocks before we get new stocks? Are we considering empowering them? Inefficient procurement processes. How are we involving the procurement team? How are we building their capacities? How are we including them in our meetings to know that the procurement processes also play a key role in having access to essential medicines in the facility? The key medications we need. You go to the procurement and they will tell you, oh, we are on it. The supplier will come. Meanwhile, we are running out of the stocks. Because they don't know, they don't understand. How are we involving them and building their capacity to understand the need to have access to essential medicines all the time? We look at quality and supply risks. Let's talk about counterfeit and substandard medicines. WHO is saying that 10 to 20% of sampled medicines fail quality control tests in many developing countries. Why should it be so? The essential medicines meant to treat our clients, 10 to 20% of them fail quality tests. What are we doing about it as a DTC team? 28% of these counterfeit medicines are antibiotics. The antibiotics that are supposed to treat the infections for better healthcare outcomes, 28% of them are counterfeits. Expired medicines, a costly favor. 15 to 25% of all medicines that are procured expire before they get to be used. Why should it be so? Are we monitoring our stocks enough? Are we making sure that when suppliers bring the stocks, we are checking the expiry dates? Are we monitoring the prescribing pattern so that if a particular product are not moving because prescribing patterns have changed, how best are we going to go about it so we don't get expiries? In the first place, we don't have the money, but we are sitting down for our stocks to expire because we are not being proactive. Once we realize prescribing patterns have changed, why can't we redistribute these stocks among sister facilities so they don't get expired in our facilities? And because of expired products, annually, sub-Saharan Africa, we are losing about $12 billion to expired products. This $12 billion can do a lot for our health system. So let's avoid the expiries and make sure we manage the stocks very well. Let's look at the 5 pillars for scaling up access. How can we scale up access? The first is careful selection of medicines. As a DTC team, if we make sure we select these medicines we need, I know we will scale up access. So we don't end up stocking the medicines that we don't really use, but we stock the medicines that are needed in our facilities. Formulary optimization. The formulary we are using in our facility, how well are we updating them? We just develop the formulary and just leave it, and it will take about a year, 2, 3 years before we update them. Forecasting, quantification, and supply planning. How are we forecasting the medications that we use in our facility? Quantification. How are we doing it? Are we using the consumption data, or we are just, assuming, oh, as for paracetamol here, every year we use plenty, so let's order plenty. Our quantification backed by data. The workforce capacity development. How are we giving ourselves refresher trainings like we are doing right now? We are refreshing ourselves. How well are we supporting our colleagues to build our capacity? So looking at the first pillar, that's the careful selection of the medicines. Just like we said, selection should rest on current evidence and local data. Are our selections based on evidence, or we just want to develop a formulary, so we just develop anything? Let's look at the second pillar, formulary optimization. How often are we updating the formulary? Are we reading around to know the modern medications that are being used in treatment of some new infections and probably added to our formulary, or
we are just leaving the formulary because we have developed one. You need be an enye, you will be formulary, you will be, so we don't care to update it. Looking at forecasting, quantification, and supply planning. Are we looking at the staff that are involved when it comes to forecasting and quantification? Are we empowering them? Are we building their capacity? Are we letting them know our consumption pattern, the consumption data, the average monthly consumption of each of the medications we have in the facility? Do they know? Are they aware? Because they don't have these data, they end up quantifying anything. Oh, for paracetamol, we used about 10 cartons last year. So this year, you for 1 carton and come. Or we are supporting them to empower them to know how to use the average monthly consumptions of each of the products we use to back their quantification, so we don't end up overstocking or understocking. When we overstock, it ends up expiring, and disposing them of will cost us a lot of money. Let's look at pooled procurement. Are we taking advantage of pooled procurement whereby we have bargaining power to make sure that our stocks, the prices are affordable for our clients? Are we taking advantage of that framework contracting? That is also another form of pooled procurement. Let's look at the workforce capacity building. How often have we planned as a DTC team to have some of these meetings to build our own capacity and also build the capacity of the other units that are not privileged to be part of our team? Let's think about all these things. So beyond the medicines, what else can we think about? Are we thinking about the diagnostics? Are we thinking about the devices that will help us get our treatment right on point? Are we looking at availability of vaccines to prevent most of these infectious diseases that will, at the end of the day, end up making us use more of these antibiotics? Are we encouraging the mothers to bring their babies for vaccination? I know some of we, the health workers, we don't believe in vaccinations, but have we thought of how good it will be if we get vaccinated and we are prevented from contracting these preventable infectious diseases, so we don't end up using a lot of medications or antibiotics? What are some of the takeaways of these presentations we've had today, including this one? We are talking about access failure, which drives antimicrobial resistance. So if we don't quantify well and we don't procure on time, we won't have access to essential medicines, and this will drive antimicrobial resistance. We are talking about the 3 A's. That's the appropriateness of the medications we are stocking, the availability, and then the affordability. Have we looked at that? How affordable are our medications in the facility? Are our clients being able to afford them when we prescribe to them? We've also spoken about quality assurance, the counterfeits, the substandard medications, and the expired medications. And finally, we've spoken about people being the foundation of everything we do. Building the capacity of our workforce is the foundation of everything we do. Thank you very much for your attention.
Any questions, suggestions, contributions?
The comment I have with the quantification aspect, maybe not a question because you may not be in the proper position, but if you look at the area of antiretroviral, probably the director might have some comment on that if he's well positioned. You realize that sometimes we have periods when we have more like a shortage or very limited stocks. You order, you don't get the quantities you need. And then another time comes and then huge quantities are pushed to facilities with very short shelf life. So what are we doing at those higher levels to, like you said, sometimes we lose a lot of money as a result of expiries. But once these short-dated items are brought down to the facilities, expiry is inevitable. So what can we do to save our money in those arrangements, those levels as well?
Okay, so you mentioned
antiretrovirals,
especially the program drugs. We don't procure them ourselves as a country. The partners usually procure them for us. And sometimes they come in country and they are stuck at the ports because they want the donor to be the one to pay all the ports clearing monies before they are released to us. And the donor too sometimes doesn't want to do it because I've procured the things for you, I've shipped it to you for free, and you expect me to come and clear it at your port again. And the government will say they don't have money, and the stocks will be at the port all this while. So by the time government gets money to clear it, the expiry date gets so close, and that's how come it happens like that. So money, let's hope that some dedicated funding will be reserved for such things and clear them for us on time, so we don't end up getting this expired medication on our hands.
Are we okay with
I thought that the actual people to take those decisions are far above the level of it.
Yes, it's at the ministerial
level,
but it's interministerial between the health ministry and the finance ministry, not solely with the health ministry. But very soon, global fund is specific out. Therefore, yeah. So if we start buying our own antivirals, then yes, we'll clear.
I also want to find out how at the facility level substandard medications
Okay. Well, at the facility level, sometimes with our naked eye, we might not know this particular product is substandard. But if we are monitoring, you give the medication to the client and the client comes back and it's not working, they are not getting cured. If we are really monitoring, we get to know that there's something happening, and probably we then take samples and involve FDA to recheck for us. Sometimes if we monitor very well, we see some differences in packaging, some defects, and that should raise an alarm to know that these medications, let's watch it very well for this substandard counterfeit.
Most of the disability.
Okay. Well, so to add to what Barry said, I know FDA is collaborating with the Ghana Health Service to run what we call pharmaceutical traceability. Yes, so there are devices they are deploying to help us trace some of these substandard products. But also at the facility level, I know in procuring, it is a requirement now that the supplier also provides the FDA certificate. It has to be valid. If it is not, you can't supply. I don't know if it's done. If it's done here.
Yes, the suppliers is part of the pre-qualification criteria. So the supplier has to bring these documents, and even further, when they are delivering, sometimes yes, supply, especially when there are new items and all of that, they have to attach FDA certificates. Even in some cases, if they previously supplied and we, like she said, we encounter we can call for the FDA certificate again. Maybe it might be expired or something, and we follow it up.
So these are some of the ways we address system.
Is any other?
What about the expired medicines? Have you spoken about it? Is that all? You used to read the antivirus, the system. The other side, the essential medicines. Because given what she said, if you are listening as much as let's imagine that man was given to them. We're talking about the health care institution.
Yes.
Hey, are you sure? That one is too big for the health sector.
Send globally.
I know that what is lost in Africa. If that money had been given to Ghana, just imagine what 12 billion can do to Ghana. It can do a lot. It's far beyond the capacity of the health sector. So it's not a huge amount of money. Now you are listening a lot. Like she rightly said, you don't have enough. The little you allow 1/3 of the population now have access to medicines. Then you allow 15 to 25% to get this back. Okay? What sort of money do you get? All right, that's
Please, any other? Before we move on, those who joined today, there are 2 links on the DCC page. Kindly click on them. Okay, a big round of applause. So we move to the last presentation on the to be done by posters.
Okay, the next one, we will not spend so much time. It's briefly, we were going to support you to do an action plan for the ALS. But already, you've gone ahead of us. We already have an action plan. So we will collect it and then peruse it, and where there are gaps, we will support you with it. The other thing is that we are planning to have a common platform for Ghana Health Service, AMS teams, so that we learn from each other. Some have gone ahead, you are doing well, some are even about to now start. So we want to build the capacity and support each other with it. So that's about it for this.
So please, that's the posters. We have about 3 minutes.
Someone has posted the link on DTC, so you can just.
So as we are still on our post test, we will do an evaluation for this workshop. It's very short. If you are done, you raise your hand so I can. Okay, so we'll move on to closing remarks from director. Let's go on. IHP, okay. So IHP will come then. Director, then Ahmed, we'll take our closing prayer.
All right. So I bring you greetings again from IHP, that the Integrated Health Partnership Activity Project, also known as Project Hope. What I would want to say is that we know now most of our partners are no more supporting us any longer. Most of the partners have folded up. And lo and behold, President Trump has seen that when it comes to maternal and child health, it's very key and dear to everybody's heart. So therefore, he's still supporting Project Hope to support, strengthen our own health systems. So with this, we will have to take advantage of this opportunity and make good use of it while it lasts, because we don't know what will happen tomorrow. he can decide not to also continue to support us again. So the little that is bringing, and we also coming to build our capacity and learning, how are we going to put them into good use to support, strengthen the health system that belongs to all of us. So as we go back to our various units, how are we going to impact this knowledge that we've acquired from this training to our colleagues in the units? Are we going to inform them about what we have come to learn here and also build the capacities as well and help to promote the strengthening of the system that we are in? So tomorrow, if the support doesn't come again, how well have we used the little we had? So that is the information I have for you. Let's take the opportunity, let's take the advantage. Anytime there's a training, anytime there's capacity building, let's try to learn and build our own capacity and build the capacity of our colleagues who didn't get the opportunities to be part of this training. Thank you very much. The talk says thank you for your time and thank you for participating in this activity.
All right, so thank you. There was this quote that Marina kept on projecting before every presentation. Who can say it?
There was one about measurement, another one. I forgot the exact way, but if you can't measure it, then it's not worth doing or something.
All right, so that you can't improve what you can't measure. You can't improve what you can't measure. So in case you are asked to substitute a word for improve, like I was saying in a couple of words, improve. Oh. Yeah, there you go. What was the place? Is there a place that so it's kind of same? How do you call that? Synonym. So let's look for synonym. Never call it. How is it going? Upgrade what you done. Okay, what's again? Enhance what you can measure. What's the right? Advance what you can measure.
Refine.
Outdo what you can measure.
Refine.
Level up, uplift.
Or facelift.
Alright. So you can't improve or you can't manage what you can't measure. So I want to thank all of us for this wonderful workshop. In fact, I've enjoyed it so much. And I'm grateful to the team. Nsawam Govt. First, I will commend you for the good work that you are doing. I'm so much impressed. And I'll commend for the pharmacy. He kept on pestering and every now and then when you go to you that will come in. It was very important. So thank you so much. And I'm not really surprised. In some hospitals, I think the capacity is quite high. And I'm so much impressed. Given the post-test that we had, I think the average was about 98%. 98%. That's very, very high. I think the highest so far. So, like we all been talking about, when it comes to issues of ETC, ALS, is the key thing that stands out is teamwork. So the one health approach that we've preached about should translate into teamwork at this very moment. One fellow cannot do it all. Prescribers cannot do it all. Nurses cannot do it all. Lab cannot do it all. Pharmacy cannot do it all. We must all integrate so that we deliver. So what we'll leave you with is that please stay together as one team and see how best you can strengthen your DTC and AMS. Because at headquarters, we get a bit worried as to why DTC don't thrive in healthcare institutions. Like we said, if management support and with strong intrinsic motivation, we can strengthen it in our institution. I also want to use this opportunity to thank all the people who did the facilitation, those from the office itself, those from IC. Doc, thank you so much for traveling all the way from Accra to support us. Those from lab, head of lab, Dr. Nsawam Govt, and everybody. And we thank you to the audience for sitting down through us. In fact, throughout the training session, I saw that people were very, very attentive and asked very, very intelligent questions. So thank you so very much. And please keep the fire burning. Don't let it die. Should I come back again? So we have 9.8. Yes, we've measured it. Right. Yes. We expect the next time we come and what to improve upon. So that I thank all of us. God bless us.
But just to thank the director and the team for making it possible for this presentation and this training to go. And I also appreciate that you're able to recognize what our facility has been doing and has done so far. And I'm sure that this training is going to go a long way to improve what we have already started. And we know that we are going to do much, much better. And it's going to guide what we do going forward. You said it, that IPC, AMS, GCT are supposed to work together. I know we've been working together, and I know that going forward is going to be better. And the motivation aspect, I mean, Dr. Hussein mentioned that there's been some motivation for them. But just like you said, the intrinsic part is also very, very important. Yes. And we know that going forward, we are going to make sure that things get better so that we can get the result that we all expect. And that national will still see the things that is expected of us. And at the end of the day, the best that we need for our patients will also be realized. Thank you so much for coming. Thank you.
Good afternoon, everyone. As we come to the end, I want to say a very big thank you to the Director General Ghana Health Service for sending people right from Accra to come and take us through this training. It's really going to help us intensify our stewardship duties, and it's going to, at the long run, reduce the AMR burden that we have in the country. Also, our facilitators, you did a marvelous work. Thank you very much. Our head of institution, Representative Dr. Leslie, thank you for staying through. Our nurse manager, we are grateful unto you. And to the entire management, and then to you facilitators, thank you very much for staying through up to the end of this presentation. Thank you.
We take our closing prayer for Dr. Singh.
Let's pray. We thank you, our Heavenly Father, for how far you have brought us. You started with us yesterday in the morning, you've kept us through to the end. We've learned many lessons. We pray for the strength, the wisdom, all the other resources that we need to implement them, so that at the end of the day, when AMR burden reduces, all of us, including our clients, will benefit, and the glory will be unto you. For those traveling, we commit them into your hands, carry them on eagle's wings back to their homes safely, so that they will always remember that you alone are God. Thank you for an answered prayer in Jesus' name. Amen.
Amen. Thank you.